Director Geriatric Mental Health Services at Asha Hospital. Is a past President IPS South Zone Branch, Vice President ARDSI Hyderabad, Deccan. I would like to introduce Dr. O. Jyoti Madam Garu, is a consultant psychiatrist at Asha Hospital, and her special interest was in geriatric psychiatry. Now I would like to request Dr. K. Chandrasekhar Garu to introduce our speaker. Thank you, sir.
She had joined our Asha Hospital 3 years back. She did her MBBS and post-graduation in Maharashtra. She is hardworking and pleasant to the colleagues, and learned Telugu within no time and started communicating with our patients very comfortably. Now she started working in geriatric services. Oh, sir. You can start the session.
Thank you, Madam. Respected chairpersons, delegates, my seniors, my friends and colleagues, a very good morning to all of you. First of all, I would like to thank all the organizers and Prasad sir for giving me this opportunity to speak today. I was a little surprised when I was given this topic, as I'm least techie person, but sir, I will do my best to do justice with this topic, as it is always an honor and privilege to take guidance from all my seniors in Asha Hospital. As we all are witnessing a huge surge in technological advancement and use of these devices, considering the current inevitable situation, the restrictions because of the pandemic and limitations because of it, technology has become a very important part of our life, and more too significantly in the lives of elderly people. Globally, the aging population is increasing, so as in our country as well. The 60 plus age group population is increasing consistently. It is estimated that by the end of 2050, more than 35% population will belong to either pre-retirement or retirement age group. So our population pyramid, which currently looks like this, may look like by the end of 2050 like this. That means if the trend continues, there is possibly that elderly will be a significant number of population. With changing population trend, there are changes in the living trends as well. There is increased desire among elderly to live independently and improve their quality of life. The reasons could be migration of kids for studies, for various career opportunities, and there is increased trend in nuclear family also. Almost 15 million senior citizens live alone in India. Of them, as many as 75% are women, amounting to widows and divorcees. Tamil Nadu is one state where the ratio of senior citizens to young living alone is 1:11. With advancing age, while staying alone, they might be victims of a lot of challenges, like social isolation, financial problems, safety issues, risk of fall, injuries, their physical safety, issues with nutrition, hygiene, health monitoring, medication management, etc. Mental health and well-being, they are as important as in older age as at any other time of the life. They can amount for 6.6% of total tallies in this age group. So, but still our elderly, they love to stay alone and they love their age-old habit. The reasons could be physical stress of moving. A move to senior living may mean changing decade-old routines, and some senior citizens, they worry that a move will further isolate them from their friendships. Also, a home is a place which has been cherished for life. So leaving a physical structure that has encapsulated lifelong memories and which is a backdrop to family gatherings and functions, that could become very emotional for them. They worried about some unknown fears that they can lose vulnerable relationships and they miss out the family functions or gatherings, etc. I feel that there is increased need to adapt to and utilize these newer technologies which are available by the elderlies. As there is continuous technological growth happening, which can help streamline their day-to-day activities. WHO defines healthy aging as the process of developing and maintaining the functional ability that enables the well-being of older age. So adapting to these newer technologies is one way to achieve these goals. Speaking of technology, what could be an ideal technology for elderly? It is very simply, it's just a science or knowledge that is put into practical use, which can be used to solve problems, to meet their basic needs, including health and safety, to learn new things, to make decisions, to improve their quality of life, to be mobile and independent, to build and maintain the relationship, and at the same time contributing to the society. So broadly, technologies available can be grouped into two. Assistive technologies, these are the devices and other solutions that assist people in physical, mental, or emotional functioning. And the adaptive technologies, which are specifically designed for people with certain disabilities. Smartphone, iPads, wearable devices, these are most commonly used assistive technologies. Wearable technology like smartwatches, motion trackers, they are useful in elder care and in assistant living as well. They also have a huge potential of gathering data, which is useful in health monitoring, biomedicine, and research. They gather data like EEG, ECG, EMG, heart rate, etc. From human body to give valuable information in care and management. Other applications are also being explored to predict the changes in mood and stress as well. Use of elder-friendly smartphones like those having large touch screens, circle dial phones, audio boost functions, then pen stylus to doodle and write, and with screens with emergency buttons are also available. These three have become new family members nowadays, but these are little attention seeking. Unless you call them by their name, they won't pay attention to you. So they really give a hands-free operation for people with disability and limited dexterity. Apart from that, they serve a lot of purposes in helping for having weather reports, checking events in calendar, making lists, shopping, listening to music, entertainment, communication, etc. Personal safety and safety of property is an important need while staying alone. So many devices are available like home security, safety cameras, webcams, personal alarms with panic buttons. With just push of a safety button, they can be provided help in panic and emergency situations. So they also have ability to connect with smartphone, and they help in immediate assistance. And it also gives peace of mind and satisfaction to caregivers as well, and also can help in home automation. Different types of ambient, that is non-wearable wireless sensors, are also available in the market, which are specially very useful for managing long-term behavioral problems, such as motion sensors, sensors which can be worn on the body, sound sensors, pressure sensors, etc. They can be placed at different locations in smart homes or to monitor various human behaviors, like to prevent wandering, etc. Fall risk prevention is an important task while caregiving as well as elderly for themselves. Fall detectors, they work at the principle of accelerometer. So a wearable device can be worn on the waist or hand, wrist, which is also nowadays available in smart watches. The system that detects the elderly is falling by acceleration analysis. Then the elderly, they get the elderly's geographic position and they send fall alarm with a short message to caregivers, so the help can be provided at the time of assistance. Taking care of personal items and while traveling or other things is important part of independent living for elderly. In 2014, smart shoes, also known as Lachel shoes, meaning take me along, they were described as interactive haptic footwear. So they were actually launched in 2014. It is a smart technology. It was launched in Hyderabad by two young technology students in MIT. These shoes and soles, they are connected to smartphone apps that uses Google Maps, and they vibrate to tell users when and where to turn and reach their destination. So they were actually designed for blind people, but they are very helpful for elderly as well. Then GPS trackers can also be installed to locate their items and belongings. Apart from these uses, use of smartphones and Gmaps is very common for use of navigation and reaching the destination. Non-pharmacological technology-based interventions like use of fiber optic string lights, aroma diffusers, solar effect projectors, use of music, they have been proven very effective in few pilot studies in managing difficult behaviors such as restlessness, wandering, impulsiveness. And they have conclusive results with caregiver satisfaction as well. So use of multisensory technology was found to be reducing agitation and anxiety as well. Coming to telepsychiatry, which has shown an exponential surge in last year with teleconsultation. It has been observed that patients with common mental disorders like anxiety, depression, they can be treated without the requirement of visiting actually to the hospital or with in-person contact with the doctor. Guidelines have been established by IPS and NIMHANS as well for this. It may be a very good step for the people who have avoided mental health care in the past for a very long time. It could improve access to mental health care, can easily be done by smartphone or video conference, which gives a very promising opportunity for health and technology. Managing medication is also, and maintaining compliance is also an important task. Devices like automated pill dispensers could be very useful. So they release medications at a preset time and a specified times. So medications can be administered without skipping or forgetting the schedule. Each time when the pill is released, they produce loud, alarming like a sound, or they can easily be connected via Bluetooth or Wi-Fi to your smart devices, phones or tablets also. And caregiver can also get a notification that your patient or elderly has taken medication on time. Coming to apps, several healthcare apps have been developed by healthcare and software engineers. Some apps are just standalone programs that promise to improve the memory, thinking skills. Others, they just help to connect with peer counselors or healthcare professionals. There are thousands of mental health apps available on Android and iTunes, and the number is growing each year. However, this technology frontier includes a lot of uncertainty, which I'll be discussing later. So apps, cognitive apps, they are becoming steadily popular due to its accessibility and ease of use and offering minimal interference with activities of daily living. So despite the number of benefits, I would say it's not very clear whether the use of these apps is a reliable approach that can be recommended in regular clinical practice or not. So apps are available for cognitive remediation like CogPack, CogSmart, apps for skill training, apps for increasing attention span, problem solving, or just self-management apps are also available. Another application of technology is virtual reality. It has become a booming industry. While it just started with use of playing video games, its use has become very widely in healthcare to train the medical professionals as well. No wires, no computers, simply just wearing headset makes it very convenient for elderly. Virtual reality based exer games, they have been tested to be very effective in reducing depressive symptoms and increasing physical activity among those with serious mental health issues as well as. And for supporting the cognitive and physical functions among the older adults. It has also been proved to be effective in increased social well-being or reduced loneliness via improving participation in fun and social activities, particularly among the older people. Active Brain Trainer is a platform, it's also a virtual reality exergame platform which uses motion interaction to potentially promote the better motor and cognitive rehabilitation, which is useful to improve daily function in patients following stroke or acquired brain injury. It helps practice thinking and memory attention skills while using the real-life interactive situation. So suppose if a person is on a beach or is in market, etc. Mobi Assist, another virtual reality exergame platform. It is an ICT-based system. So it has series of strength, balance, and training exercises which improve balance and coordination. They have a lot of games like Apple, Mole game, Wheel of Fortune game. Many a times the links have been generated or they are circulated on WhatsApp for Apple and Mole game, and the Wheel of Fortune game also. So these games are aimed at problem solving and improving other cognitive tasks. Online support group is another emerging application of technology. Benefits of joining online support groups and forums, they can include reduced isolation, depression, or anxiety. So caregivers, they feel more empowered to handle the situation as they get the better ideas. And it is also a non-judgmental platform where they can freely ask questions and they can share their experiences. So for those who are not very comfortable attending physically and for those who lack time and resources like transport, it is a very useful platform. Now coming to the adaptive technologies, these are something which are designed for people with disabilities. Use of simply the adaptive utensils like a simple spoon which adapts to the tremors of the hand, or just a bowl which has a vacuum seal, it can help to a significant extent for managing eating independently. Audiobooks for people who have comprehension difficulty by reading, smart chairs and uplift seats assist for easy mobility, then TV ears to hear dialogues clearly while they can reduce the volume for others at the same time. So elderly can sit with a family member and enjoy at the same time. Then voice control alarm clocks, buttoning aid and hooks for people with limited dexterity. These are just few examples. Now coming to the dementia care, technology has multiple potential applications to dementia care, from diagnostics, assessments to care delivery and supporting aging in place. This is just a review from an article from Journal of Neurology showing various tab-based cognitive assessments, in which the most peer-reviewed and published is CanTab PAL. It's a peer-assisted learning which is administered by touchscreen tabs. So 6 to 8 boxes will appear on the screen and a picture will be shown in a particular box. Then after that, that same picture appears on the blank screen and they have to identify in which box they have been shown the picture, and it is being administered serially. So it helps to assess visuospatial memory and to assess delay in the recall, etc. Another very much reviewed and published is cognitive Cogstate brief battery. It takes a very less time, 10 minutes. It self-administers, and 4 tasks like attention, memory, working memory, problem solving, etc. Simple yes and no type of question answers are there in that. It is also available in very many languages, more than like around 43 languages. Then another tab-based assessment tool is NIH tool battery. It has subtests for episodic memory, working memory, and executive functions, etc. Coming to caregiving, caregiving and management of the patients of dementia is very stressful and effortful job. Lot of assistive technologies which I discussed earlier are very useful in caregiving, such as smart devices, safety systems, sensors and pill dispensers, etc. Technology for caregiving by robotic assistants, including communication robots and information support, but not very I don't know how much it's useful in Indian context, but Japanese studies, they have shown significant improvement in increasing participation in managing ADL in patients of mild cognitive impairment. Apart from that, use of electronic calendars, schedulers, picture phones, and simpler remote controls, they can also be very useful to a great extent in managing activities of daily living. Maintaining communication and social relationships is a crucial to the emotional well-being of elderly. Use of video calling platform has increased a lot, especially since the pandemic restrictions, and to believe that it can continue still longer. Elderly have accepted it's a new way to connect with loved one. In a survey from AARP, it has shown that almost 4 out of 5 people of age group more than 50, they rely on technology to stay connected in touch with family and friends. Another use of technology in dementia care and management is cognitive remediation. The major types of technology applied includes computerized softwares, tablets, gaming consoles, and virtual reality platform. So significant results in review studies are there in improving attention, executive functions, memory, as well as reducing the anxiety and depressive symptoms, and also for managing activities of daily livings. So different platforms like PSS Cog Rehab, which is a software with modules designed to improve cognitive deficits, then computer interactive reminiscence and conversation aid, or computerized cognitive training programs. These are the methodologies for training mental health centers to use computer-based cognitive remediation program in treatment of patients who have persistent mental health illness or patients with traumatic brain injury. Future scopes of technology in elder care could be investing in smart homes or retirement homes. So in India is just in a starting phase. Few housing groups of industries like Lavasa, Asian Homes, they are offering the solutions of smart homes and retirement homes, which are like homes equipped with a lot of functional monitoring, virtual reality kitchens, safety monitoring, physiological monitoring equipments, health monitoring, security, etc. Another future scoping could be nanotechnology, either to repair brain damage or for use of the drug delivery. Epidermal electronic is another emerging technology wherein wearable devices, they can be mounted onto the skin, either in dermal or subdermal layer. They give the monitoring of the physiological and metabolic processes, which could be very convenient, thin, soft, flexible, or they just resemble like a tattoo on the skin. So with lot of promise and ease offered by these technologies, definitely there is increased acceptability of use in elderly. The reasons could be simplicity they offer, the convenience, independence, sense of well-being and satisfaction and worthiness. A therapist or clinician can address multiple population at a time. They are more appealing sometimes than the traditional methods. They give opportunity of round-the-clock monitoring and support. Lower cost or free apps and services sometimes can be more useful. And also, the clients can seek treatment options without involving other people. At the same time, along with the patient, it's also useful and advantageous to caregivers by reducing the time needed for the assistance and care, reducing the energy put towards the caregiving, reducing the anxiety, fear, and managing the difficult tasks, safety risk of activities which involve the physical attention assistance. So suppose when patient is aggressive and impulsive, for managing tasks like taking them to bath or taking them out, etc. Sometimes it can reduce financial burden. Despite lot of advancements and availability of technological support, there are multiple challenges faced by elderly for effective utilization of these services. Advancing age comes with many physical disabilities like visual impairment, hearing impairment, etc. Reduced mobility can make use of these technologies very challenging. They might struggle with touch screen also for reasons of leathery fingers, etc., just to state. Many handheld devices like smartphone, tablets, they need hand-eye coordination. So impaired manual dexterity with age and with some neurodegenerative condition could be a challenging thing. The pace at which the technology is developing places a significant demand on elderly to learn these technologies. Those who are raised in digital world still hit these obstacles over time and find it hard to adapt, particularly after leaving the workforce. Cognitive impairments like attention, memory, visuospatial, and problem-solving difficulties can hinder with effective use of these technologies. Cognitive disabilities are the least studied disability categories. Hence, there are very limited and accessible technologies available for elderly. Usually, the elderly will take longer time to think and respond. Sometimes there are a lot of distractions, advertisement on the screen, so they can have difficulties while managing a task in their hand. They can forget the password, they can get easily logged out of that account. They may need a longer time to think and respond. Internet can empower us with lot of information, but at the same time it can be overloaded with lot of information and dark information and full of terrors for elderly who are just learning to adapt to these newer technologies or learning to just get familiar with these newer technologies. So that this could result in discontinuation of its use. There is always need of assistance to learn handheld devices for elderly and understanding how it works. Like anyone else, elderly also learn very well with one-to-one tutorials. But on most occasions, when they are living alone or when the young members of the family, they're not paying a lot of concerns and teaching them, or sometimes elderly, they themselves might feel ashamed to ask this, which can create a sense of embarrassment and might result in disinterest and discontinuation of use of these technological services. Some of the concerns raised by WHO is diversity and inequity. There is no typical old person. Two people of same age group, say suppose 80 years, they may not have same mental and physical capacity. A large proportion of diversity and inequity, it is a result of cumulative impact of advantages and disadvantages faced throughout the life. It also amounts to relationships, the environment in which they were raised, the race, ethnicity, sex, religion, a lot of factors contribute to it. Same as it is there in our country. There is no typical Indian elderly as well. Elderly in our country, they belong to different educational, financial, independent backgrounds. They have different affordabilities. Cultural differences are very significant in our country. There is a very strong family model of care. There is very strong stigma of abandonment exists. And the availability of opportunities and resources, internet, electricity is not same everywhere in India. There are a lot of unrecognizable contributions of elderly are there in our Indian context. Like elderly are supposed to take care of their grandchildren, take care of home, managing a lot of daily chores of the home, for which they are not paid. So there's a lot of unpaid jobs they are doing, which can lead to elder abuse as well. And also at the same time, there is lack of awareness about the mental health conditions as well in the elderly. The government digital exclusion strategy established in 2019 in UK by GD Services, they have found that elderly, these are the marginalized and penalized because of the limited access to and understanding of the digital world. So they have found that elderly people are one of the 5 group of people who are very vulnerable and disadvantaged group of society, which are can be easily digitally excluded. So it's observed that older adults, they use significantly fewer technology or apps, or they spend very less time on internet. But the resistance to use is not primarily rooted in accessibility issues. So this has been observed by Lancaster University Services. They stated few factors which holds back use of technological services for the elderly. There could be personally held values to do with desirability of the technology, or the fear of getting things wrong while doing something or while using the software. Some might feel it's very arduous or it's very time consuming. They feel burdensome or to become experts in all manners and thinking. Then security concerns were omnipresent and lacking confidence in their knowledge. Safety of personal details and regulations while using these services is a serious concern. Apps, they deal with very sensitive personal information. Although most of the apps, they try to maintain the privacy, but some of the assistive technologies, they do record videos and they store videos, so which could be unsettling for elderly. There is a huge gap that needs to be addressed by the industry as well as the government. Who will or who should regulate the mental health technology is a question. So it is critical that a due consideration is given to the potential ethical ramification at an individual, organizational, and societal level. The biggest concern is obtaining scientific data that they work, and they work as good as the traditional methods. On effectiveness, there are inconclusive results. There is a very little industry regulation as well as and very little information on app effectiveness, which can lead consumers to wonder which app they should trust and which they shouldn't trust. Also, there can be some disadvantages, or we can say some negative impacts of technology while elderly are using them. They could act as a double-edged sword for elderly people. So as they are retired and they have a lot of spare time, once they find it interesting, it can possibly lead to problematic internet use. There are reports on causing it more isolation, emotional loneliness, reports on reduced physical activity, increasing sedentary lifestyle, risk of cognitive decline, decreased real-life social participation and relationship problems. There are case reports on online gambling, compulsive buying and shopping, binge eating in elderly. And it has also been said that it can trigger a vicious circle of psychological disturbances like depression, anxiety, and sleep disturbances. Despite these limitations, it is very crucial that in this digital era, we come up with some solutions or ways to overcome and help our elderly population as well as to make them an integral part of this digital world. Integrational educational programs for young technology designers can be a solution for that. Understanding older adults' perception of technology, which is an important thing to assist with introducing it to this population and maximizing the potential of technology to facilitate the independent living. Also, educating the untrained elderly is an essential step in order to become familiar with the technologies. So young members of the society can come. A lot of NGOs are coming up from the young members of the technology-friendly institutes who are trying to educate elderly people how to get familiar with the use of these smart devices. To conclude, I would like to just state Ferguson and Damodaran. Widespread digital participation can only come about through the confident and successful take-up by older people and others in the digital world and the way these services are relevant to their needs and designs and presented. Only if we can have a technology. Thank you very much.
Thank you, Dr. Saqib, for an exhaustive and lucid presentation. I think both in the field of elderly care, probably there are a lot of assistive for a given individual and how to customize for a given individual, that is still a challenging task for the clinician or any other person advising them.
True, sir.
I think the topic is open for any questions.
Thank you very much. Sense.
Thank you very much.
I am a certified senior citizen. Old age man, I thought that, okay, right, I have. As you said, I wear an Apple Watch. So, but I tripped and fell down. I just in my no, MS something happened. Then continuously this is means that like useful. Miss Robo, an ambulance, do you want a coffee? An ambulance, do you want a coffee? I said, call me an ambulance. He took it as, I'm asking her to call me an ambulance from tomorrow. And then he said, an ambulance, you want a coffee? So that is where AI systems have to be, adjusted. People are broadly divided into natives and immigrants. Now you are digital native. I am a digital immigrant. Thank you.
Thank you, sir.
Excellent presentation, ma'am. This is not about technology in geriatrics, but technology on a whole. So, technology has become part and parcel of our life, and technology is evolving. So, there is no go. We need to adapt to that and use it in a proper way for betterment. So, I want to give an example. Last COVID wave in Dubai, they converted a World Trade Center building to a 3,000-bedded COVID hospital. So in the hospital, the whole rounds were done by robots. The robot will go to each and every patient, check the vitals, talk with the patient, take the data to the consultant, and also it makes a video call to the family members, and it used to serve food and everything. Everything was done by robots itself in that hospital in Dubai. So I feel technology is for betterment, but we should use it in a proper way.
Definitely.
Yeah. Thank you.
Dr. M.S. Reddy said that he's a certified senior citizen. I'm not yet. But having said that, Sakib, a wonderful presentation.
Thank you, sir.
What I just need to add, and I thought for the geriatric population, which I have been using regularly for the last 2 years or so, is a simple game called Peak. The app is called Peak, P-E-A-K, which has an attention concentration, short memory, vocabulary, and visual memory. All this, it takes about 10 minutes only. I am just following this for some time, and very interestingly in my dementia patients, especially once they are trained, it just takes less than 1 hour to train. Less than 1 hour. Actually it is 15-20 minutes. Because Peak should be downloaded and after that we show. In that group, actually they are getting active, and it is addictive in a sense because there is a score which comes, and your everyday score as a graph, it comes as a multiple. That is one experience. The second thing which has changed, as I think MSD has already talked about, the smartphone. Today, in whoever has smartphone, or even I'm asking patients to keep the mobile phone, it records the sleep. It gives actually the REM and NREM also. So this is one own very simple technology within your own smartphones. You know, the health app which is embedded in almost Samsung or iPhone. So these are the two things which is probably I'm using, and I think it's good that each one of us sitting here will start practicing some important apps. But I would agree with you in the end that it should be personalized, and it should be for each individual what you want to do and what you want to measure. And last, the cognitive training. There are few apps which I have tried. Little difficult in the beginning, but once if there is an intelligent caregiver, I think we are able to work with it. Thank you for the nice presentation.
Thank you, sir.
I think there are not any questions. I think we'll close this session. Thank you, Dr. Saqib, once again.
Thank you, sir. Thank you, ma'am. I request Dr. K. Chandrasekhar garu and Dr. O. Jyotirmayan garu to give the token of appreciation to our speaker. I also request Dr. Saqib Ma'am Garu to honor our chairpersons. Next. Thank you, sir. Before going to the next session, I would like to make an announcement. The debate topic has been preponed as our Dr. Vijay Seshadri Garu could not make it due to some unavoidable circumstances. His topic was cancelled, and the debate topic will be start at 2:30 p.m. and hence the validatory function will start by 3:15 p.m. Moving on to the next session. Our topic is OCD, its newer perspective. The chairpersons, I would like to invite Dr. Rennie D'Souza Garu and Dr. K. Anil Reddy Garu to come onto the dais and chair the session. I also request Dr. Vasishta BSG Garu to come onto the dais and speak about this topic. Dr. Rennie D'Souza Garu, she is a professor and HOD of Psychiatry at Kamineni Academy of Sciences and Research Center, LB Nagar, Hyderabad. She has over 25 years of teaching experience. Regarding PG internal, external as external examiner, presented CMEs at local, state level, participated in state, national and international conferences. She was ex-vice president of Hyderabad Psychiatric Society. I'm glad to introduce Dr. Anil Reddy Garu. He is a consultant psychiatrist at Asha Hospital. He was trained in RTMS protocols for major depression and OCD from AIMS, New Delhi. He major contributed to a chapter in Handbook of Dementia, Thoughts, Themes and Variations, sponsored by ARDSA. Now I hand over the mic to our chairpersons to introduce the speaker of the topic.
Yeah, good morning, one and all. Thank you, Dr. Prasad Rao, for giving me this opportunity and privilege for chairing this session, topic of which is OCD, a newer perspective. Yes, and the speaker for today, as you know, is Dr. BSG Vasista. He's a consultant psychiatrist at the Manasa Neuropsychiatric Counseling Center at Warangal. Yes. Okay. And it gives me a great pleasure to have Dr. Anil Reddy as the co-chairperson. Now, coming to OCD, we all know that OCD was once a neglected illness, but now it is a commonly, or it's recognized as a commonly early diagnosed, treatable brain disorder, okay? And over the last 10 years, a lot of advances, or research has contributed to substantial advances in understanding the phenomenology, the brain-based biology, the treatment response, which has led to innovations in the nosological, conceptualization, treatment, therapeutic interventions and services. Now, coming to the recent changes in DSM-5 and ICD-11 in the diagnostic classification, OCD has been set at the head of a new, what you call it, OC spectrum disorder or OC-related disorder, where the compulsive or compulsion is a characteristic or a cardinal feature among all these disorders. Again, research also has shown that in DSM-5, you have a specifier where they say insight helps in the prognosis. So we'll hear more about it, I guess, from Dr. Vasista. Another thing which I would like to mention, that the Niemann's OCD Clinic had organized this International Symposium on OCD-related disorders in October 2017, and a lot of papers were presented there. And another paper which has given more importance was the progress in the what you call the neuroanatomical correlates of OCD. Like we know that the corticostriatal thalamocortical circuits are important in OCD, but here they have also mentioned that parietal cortex, cerebrum also plays a role. Not to forget, we know that psychotherapy also is plays an important role in the treatment of OCD, especially exposure response prevention, CBT. But there is a newer therapy which is known as the third wave therapy or a new wave therapy, which includes metacognition and mindfulness. And finally, a lot is spoken about the brain stimulation, both invasive and non-invasive. So I'll hand over the mic to my co-chairperson to introduce the speaker. Over to you, Dr. Anil.
Thank you, ma'am. At the outset, I would like to thank Dr. G. Prasad Rao Garu and Ipstsb and TS Psycon for inviting me to be the co-chair along with Dr. Enu D'Souza. I'd like to give a brief bio CV about Dr. Vasishta. Dr. Vasishta finished his graduation MBBS from Chelmed Anand Rao Institute of Medical Sciences, Karimnagar, and did his diploma in psychiatry from IMH, Hyderabad, and has worked as a senior resident at Kakatiya Medical College, Warangal, and I've had the great pleasure to work with him at Asha Hospital when he was a junior psychiatrist there. His areas of interest are schizophrenia, OCD, liaison psychiatry. He is presently working as a consultant psychiatrist in Warangal. Dr. Vasishta, please start this.
Good afternoon, one and all. Thank you very much for giving me this opportunity, sir. I thank the organizing committee and my guru, Dr. Prasad Rao, sir, for giving me this opportunity. My topic is OCD and its newer perspective. Let me give a brief introduction about OCD. OCD is one of the neglected diseases, and OCD as such, its presentation is as a separate entity. It is very unique from other psychiatric disorders. OCD, it is obsession. It is characterized by obsessions as well as compulsions. OCD is characterized by repetitive, intrusive thoughts and mental acts or behaviors in response to those thoughts. And either obsessions or compulsions or both may be present in the clinical setting. Obsessions are intrusive and unwanted repetitive thoughts, urges or impulses that often lead to a marked increase in anxiety or distress. Compulsions are repetitive behaviors or mental acts that are done in response to obsessions. The OCD cycle, the unwanted distressing thoughts or urges may include what ifs and doubts, which may produce anxiety. It may be in the form of distress, fear, worry or disgust. It creates a false alarm which may lead to a compulsive act, compulsive behavior in order to reduce the anxiety. And while performing compulsions, the temporary relief is attained. So a stimulus, which may be internal or external, leads to an obsession which gives rise to distress or anxiety, which compulsions arise as a ritualistic behavior, and this temporary relief from distress or anxiety gives reinforcement for such repetitive behaviors. DSM-5 has made very relative subtle adjustment to DSM-4 criteria to clarify the symptoms. The term impulse is replaced with urge in order to avoid confusion with impulse control disorders. And OCD has been shifted into a new chapter of OCRDs, that is obsessive compulsive related disorders. And there is an extension of the inside specifier to include absent inside. ICD-11 includes tic disorder, olfactory reference disorder and hypochondriasis in OCRDs. In coming to epidemiology, in epidemiological catchment area study and NCSR studies, lifetime prevalence of OCD is 2.3% with mean age of presentation being 19, early onset being more common in males, but community studies state that there is high prevalence of OCD in females. Comorbid tic disorder are most likely to occur in males. Coming to etiopathogenesis, learning theories, neurobiology, psychodynamic theories, neurocognition, neurochemistry and neuroanatomy and neuroimmunology. The existing neurobiological models of OCD highlights the function of frontostriato-thalamocortical circuit as a substrate for various cognitive dysfunctions in OCD, especially the executive control. Thalamus is the relay of information for conscious review of our thoughts. So, in this corticothalamo loop, which allows us to consciously review our actions and our thought process for consistency. A thought which is relayed into thalamus either from cortex, and there will be an appropriate behavior as such, which gives us relief and satisfaction. Next is the basal ganglia, which helps in generating and encoding the patterns. The caudate nucleus, putamen, globus pallidus, subthalamic nucleus, and substantia nigra are the parts of basal ganglia. The patterns are laid down as we execute an action or thought process. Basal ganglia unconsciously assembles disparate information from cortex into the correct order. The more a use of pattern, the more use of a pattern gets, the greater is the encoding strength. For habit formation, the anterior cingulate cortex, which acts as an evaluator, helps to focus our attention, emotional, cognitive, and sensory information, and to help determine what to do with it. And it is also capable of inhibiting the basal gangliar function. The orbitofrontal cortex is the emotional sensor and inhibitor, which senses our social, emotional, and environment and judges the act. The ACC and OFC both help to evaluate the emotional signals and make their way into the conscious awareness. So, normal habit, usually thoughts from ACC and OFC, which occur in a jumbled pattern of commands, are relayed into basal ganglia, which converts it into an ordered pattern of commands and relays it into the thalamus. Thereby, appropriate behavior is achieved, and there will be a sense of relief and satisfaction. Here in OCDs, the dysfunctional areas, mainly the basal ganglia and thalamus, the more intrusive thoughts, the thoughts generated in a random are increased from ACC or OFC. They come in a disorderly pattern of commands and are relayed into the basal ganglia. The relay center dysfunctions, and thereby the inappropriate behavior occurs. The cortex reviews its thoughts and again relays it into the thalamus, where there will be a lack of satisfaction, and this leads to intrusion and obsessions. So, in the corticostriatothalamic circuitry, the direct pathways and indirect pathways, hyperstimulation of direct pathway and decreased intensity by inhibitory pathway leads to the obsessions. So, are there any neuropsychological functionings? Is the executive functioning the key deficit? There is a study proposed with a sample size of 150 with DSM-4 criteria met OCD subject and 250 health controls. The deficits observed are scanning, concept formation, conflict resolution, decision making, encoding of non-verbal memory. And these are all mediated by superior and medial frontal cortex, as ACC and DLPFC. And are there neuropsychological deficit trade markers in OCD? Again, one more study by Y.C. Janardhan Reddy sir, published in 2019. 30 remitted DSM-4 individuals with 30 individually matched controls. OCD patients performed poorly on Wisconsin card sorting tests or set shifting and response inhibition, alternation, and non-verbal memory. So, the involvement of both dorsolateral prefrontal cortex and orbitofrontal cortex is observed. So, set shifting response inhibition and non-verbal memory are potential endophenotypes in this study. Neuroimaging studies in OCD. Structural imaging for grey matter, white matter, and resting state imaging for connectivity, functional MRI for cognitive activation, magnetic resonance spectroscopy for neurochemical studies, and cerebral blood flow through PET and SPECT. Structural gray matter alterations in OCD. The research of interest studies, there is volume reduction in the regions such as orbitofrontal cortex, caudate, thalamus, amygdala, and anterior cingulate cortex. Multiple studies support this with ROA studies. Then there is another meta-analysis of 14 ROA studies with reduced volume of left ACC and bilateral orbitofrontal cortex and an increase in bilateral thalamic volumes. Voxel-based morphometry studies, the meta-analysis of 12 voxel-based morphometry studies, there is increased bilateral regional grey matter volume in the lenticular nucleus extending to the caudate nucleus, as well as a decreased bilateral regional grey matter volumes in dorsal mediofrontal and anterior cingulate gyri extending to the supplementary motor area and frontal eye fields. Study published from Narayan Swamy et al. Study, the caudate volume is deficient, whereas in Venkat Subramaniam study, there is deficient anterior cingulate cortex with the cortical surface area. Both are unpublished studies. The gray matter correlates of symptom dimensions include the contamination. There is a positive correlation at the right fusiform gyrus and negative correlation at the right supramarginal gyrus. For aggressive thoughts, left anterior cingulate and right anterior cingulate. The negative correlation is at right precuneus. For pathological doubts, right medial frontal gyrus and right superior parietal lobule are positive correlations. For sexual thoughts, sexual obsessions, positive correlation at the right inferior frontal gyrus and negative correlation is at the left inferior frontal gyrus. For symmetry, left medial frontal gyrus, there is negative correlation. This is from Narayan Swamy sir study. And white matter abnormalities in OCD. 10 of the considered studies, meta-analysis shows abnormalities in the cingulum. Altered white matter integrity in the anterior and posterior limb of the internal capsule is observed from 6 papers. 6 studies found white matter abnormalities in prefrontal regions and in parieto-temporal and occipital areas. Symptom provocation paradigms with fMRI. There is activation of orbitofrontal cortex and anterior cingulate cortex during symptom provocation tasks. Increased activation in insula, parahippocampal and inferior frontal cortex during symptom provocation of patients with washing rituals. There is amygdala activation also. So this shows the patients were found to have deficient activation in bilateral anterior prefrontal, dorsolateral prefrontal, orbitofrontal, anterior cingulate, insular and parietal cortices, precuneus and caudate. This is from Agarwal study 2012. For response inhibition, the coordination of neural substrates. Various functional imaging studies in OCD have found reduced activation in frontal, temporal, parietal and striatal areas during response inhibition tasks. Both increased and decreased activation of cingulate gyrus are seen during tasks of inhibition are reported. The regions with deficient activation in cingulate cortex, caudate and dorsolateral prefrontal cortex, which are shown corresponding in red, blue and green areas. So this is from Jose et al. Study, where all these areas have been shown to have deficiencies in OCD patients. Coming to inflammation, there is an article published in JAMA through PET studies, radioligands that bind to TSPO, that is translocator protein, which is an index of TSPO density. The TSPO density increases when microglia are activated during neuroinflammation. The regional distribution of elevated TSPO argues autoimmune neuroinflammatory theories of OCD to extend beyond basal ganglia and to include CSTC circuit. The results in this study are translocator protein was significantly greater in OCD cases within the dorsal caudate, orbitofrontal cortex, thalamus, ventral striatum, dorsal putamen and ACC. Coming to the diagnosis, we usually go with DSM-5 criteria currently in use with presence of abscissions or compulsions or both. Obsessions are defined as recurrent persistent thoughts, urges, impulses that are experienced at some time during the disturbance as intrusive and unwanted. The individual attempts to ignore or suppress such thoughts, urges or images to neutralize them with some other thought or action by performing a compulsion. Compulsions are defined as repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behavior or mental acts are aimed at preventing or reducing anxiety or distress. So, the obsessions or compulsions are time consuming. These are not attributable to the physiological effects of substance or any other mental condition. The disturbance is not better explained by symptoms of another mental disorder. The specifiers are with good insight or fair insight, with poor insight, with absent insight, with delusional beliefs and tick related. ICD-11 has included hypochondriasis, olfactory reference syndrome, and Tourette syndrome in OCRDs. Whereas OCRDs in DSM-5 with body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation skin pricking disorder. Most common obsessions and corresponding compulsions seen are fear of contamination with compulsion being cleaning or washing, persistent doubting with compulsion of checking, violent sexual intrusive thoughts with repetitive undoing of thoughts, fear of causing harm, the compulsion will be repetitive behaviors of checking, symmetry with compulsion of order or arranging, religious scrupulosity with religious compulsions, superstitions with superstitious behaviors. Vivox still remains a gold standard with good internal consistency and validity to evaluate and help, which helps us in assessing the patient and during the course as well as during the treatment. For initial screening, we can use 6 brief questions such as, do you wish or clean a lot? Do you check things a lot? Is there any thought that keeps bothering you and would like to get rid of you but can't? Do your daily activities take a long time to finish? Are you concerned about your orderliness or symmetry? And do these problems trouble you? This bedside clinical assessment in a short time can give us a perspective that whether he is having OC symptoms or not. Coming to the concept of insight, it is the acknowledgement of irrational nature of OCD symptoms, and them recognizing that their experiences are excessive and unreasonable. They interference to work, ability or function. Insight is a dynamic concept. Its range varies from good insight to delusional beliefs. From good insight, fluctuating insight, poor insight, which may be and overvalued ideas, and delusional beliefs. Of OCD patients, 15 to 30% have good insight. Insight usually fluctuates. Poor insight will be a predictor of poor response to treatment, and in severe OCD and early onset and more comorbidities. The presence of tic symptoms represents another clinical relevant diagnostic specifier in DSM-5. Tic may predict a more favorable response to dopaminergic antagonists. Coming to the concept of functional impairment, it is an important domain that reflects clinical severity. It indirectly measures the improvement during treatment. There are several scales with specific measures such as the WHO Disability Assessment Schedule or Cognitive Assessment Instrument of Obsessions and Compulsions to measure the functional impairment. Comorbidities almost or always present with OCDs in a phase-specific manner, as said by Palenti et al. Tic disorders, anxiety which share a common genome of CYP3A45 genotypes, depressive disorders which share a common gene of OPRM1, disruptive disorders, eating disorders, autistic spectrum disorders, ADHD, schizophrenia and bipolar disorder. Both we may give a dual diagnosis or they may occur as a comorbidity in a OC patient. Suicidality is another concept, important concept in OC patients. Of 36% of, in a study by Torres et al., 36% reported a lifetime suicidal thoughts, in whom 20% have made suicidal plans, and 11% has already attempted suicide. 10% presented with current suicidal thoughts. So, a comorbid depressive disorder and PTSD were associated with a range of suicidal behavior in OCD patients. A study from Del Oso, there were 14.6% reported of at least one suicide attempt during their lifetime. While going with an OCD patient, always look for other disorders which we may suspect in a OC spectrum. Either it may be from a OC spectrum disorder or from other disorders such as generalized anxiety disorder, BDD, hoarding disorder, trichotillomania, excoriation disorder, stereotypic movement disorder. So, coming to the treatment usually consists of pharmacotherapy, psychotherapy in combined or somatic therapies and novel digital interventions. Current US FDA status for approved for OCD treatment are mainly SSRIs with clomipramine approved. It is approved in children about 10 years of age, fluoxetine from 8 years of age, fluvoxamine from 8 years of age, sertraline from 6 years of age. Other antipsychotics are not yet approved, and invasive procedures are not yet approved by FDA. Coming to exposure response prevention, the primary components include assessment of OC symptoms, psychoeducation and treatment rationale, symptom monitoring, developing the fear hierarchies, in-session and out-session exposure work, relapse prevention and generalized training. Defining treatment resistance. To label a patient as treatment resistance, if the response is, if the CGI score is more than 35% reduction and Vibox score is more than 35% reduction, it is called response. Partial response is more than 25% and less than 35% in reduction in Vibox. Treatment resistance to be poor response to at least one SSRI trial. Treatment refractory is poor response to at least 2 adequate SSRI trials. Stages of response as depicted in Palenti et al. 1 is recovery, that is less than 8 score on Vibox. 2 is remission, less than 16 on Vibox. 3 is full response greater than 35% reduction of Vibox score. 4 is partial response, that is more than 25% but less than 35% on Vibox. 5 non-response, less than 25% Vibox reduction. And 6 is relapse, that is symptoms return on after 3 months of adequate treatment. 6 is refractory, there is no change or worsening with all treatments. Practical definition is the poor response to at least 2 adequate trials with SSRIs and less than 35% reduction in Vibox and minimal improvement or no change or worse on CGI. In clinical terms, patient reports no significant reduction in time spent, distress and interference in functioning. Predictors of positive medication response are later onset, short duration of illness, less severe illness, female gender, absence of depression, strong family history of OCD with better insight, absence of previous SSRI trials, absence of personality disorders and absence of hoarding. Poor outcome predictors are tic disorders, schizotypal personality, poor insight, early age of onset, certain obsessions of hoarding and symmetry. NIMHANS studies, the predictors of poor outcome are mixed OCD with sexual obsessions, washing and miscellaneous compulsions, lifetime axis 1 disorder with major depression, poor insight, adults with early onset OCD, and good outcome in children. Very early onset predicts good prognosis in children. This is from Dr. Y.C. Reddy sir study in JCP 2005. So what does an adequate trial mean? Adequate dosage of any SSRI such as fluoxetine with 60 to 80 milligrams, fluoxamine 250 to 300 milligrams, sertraline up to 200 milligrams, citalopram 60 to 80 milligrams, clomipramine 150 to 250 milligrams, paroxetine 50 to 75 milligrams. The adequate period specifier is at least for a period of at least 10 to 12 weeks. All SSRIs are effective in treating this OCD. There are multiple meta-analysis and of placebo-controlled trials with clomipramine being superior to SSRIs. In any direct head-to-head comparison studies, clomipramine and SSRIs comparable to clomipramine. Venlafaxine may also be as efficacious as SSRIs. In non-response patients, diagnostic re-evaluation should always be there, and to assess insight, evaluate comorbid axis 1-2 disorders, OC spectrum disorders, tic disorders, bipolar and psychotic disorders, and see that if assessment is done, if adequately treated or not. Coming to CBT, does CBT work in resistant OCD? Expert consensus recommends CBT for who do not respond to SSRI trials, but the evidence is very sparse. 3 studies in non-responders where CBT was achieved gives encouraging results. There comes the concept of intensive residential treatment. This is followed in our NIMHANS for non-responsive patients as well as resistant cases of OCD. There are two studies which support this IRT. One is Drummond study, where there is 30 to 40% decrease in time spent on compulsions and discomfort, and Buchanan study with improvement in 44%. But the backdrop is both the studies had small sample sizes and did not use validated measures. There is one more American study with a big sample size, but the results are not that much favoring towards IRT. A residential and daycare program at McLean Hospital was conducted with a multidisciplinary team, highly structured program with 2 to 4 hours of CBT daily, with weekly pharmacological monitoring and weekly group sessions. The program length was 1 to 3 months, with a total responders were 59%, that is more than 25% reduction in Y-box care. This is a Stewart study published in Journal of Psychiatry in 2005, where the outcome measures were, the mean score showed there is significant improvement with IRT. Predictors of response to IRT are low initial severity with female gender and better baseline work and social judgment. Definitely IRT will be a good option, but it is a time consuming and intensive program. It is only feasible in institutes such as NIMHANS, where a multidisciplinary group requires to monitor this. Next comes our venlafaxine. Does venlafaxine usually work in OCD? There is a study by Hollander which clearly helps us to state that yes, definitely venlafaxine works in OCD. Coming to augmentation strategies, with SSRI being the mainstay of the treatment or clomipramine being the mainstay of treatment, the response, whether it is a partial response, we can go with an augmentation strategies with either risperidone or quetiapine, haloperidol, pimozide. Clomipramine IV, which is usually not available in some of the countries, is also used. Promising treatments include SSRIs plus clomipramine, high-dose SSRI monotherapy, anti-glutaminergic agents like riluzole, inositol, morphine, tramadol, and mirtazapine. Ineffective treatments are ECTs, anticonvulsant, buspirone, and trazodone. Role of antipsychotics. There is no evidence that antipsychotics worsen OCD, and the best evidence is atypical drugs are efficacious even in the absence of tic disorders and schizotypal disorder, published in Block et al. Intravenous clomipramine therapy in OCD refractory patients, OCD refractory to oral clomipramine and other SSRIs, as this causes to bypass the first pass metabolism in liver, result in increased ratio of CMN to desmethyl clomipramine. It is often the first augmenting agent used in some countries. RCT conducted by Fallon et al. With 54 patients non-responsive to oral clomipramine, randomized to 14 infusions of either clomipramine or placebo. After 14 infusions, 6, that is 21% of 6 out of 29 in clomipramine, much improved versus placebo, 0 out of 25. Next option is intravenous citalopram. There is a study in which 38 patients unresponsive to 2 SSRIs, initially 20 milligrams per day, later on increased to 40 to 80 milligrams per day for 21 days. 71% responded, and there is a mean decline from 38 baseline to 23 at endpoint. High dose sertraline therapy for non-responders in acute treatment. There is Neenan et al. Study with 66 non-responders to 16 weeks of sertraline, randomized to 12 weeks of 200 milligrams of sertraline. Those in the higher dose group showed greater rate of improvement, and there is no difference in the responder rates. The side effects were similar in both the groups. Extended treatment was seen to be beneficial, but in some cases there is probably a high dose therapy is beneficial in them. Addition of anti-glutaminergic agents, memantine, riluzole, and N-acetylcysteine. There are only promising results for riluzole, but RCT is needed. Non-pharmacological treatments include ECT, RTMS, TDCS, neurosurgery and deep brain stimulation. ECT, there is no published RCT to support that it is effective in OCDs. But comorbid depression or comorbid psychosis, yes, the ECT is definitely an option. RTMS is widely studied for OCD these days. Low frequency RTMS is thought to inhibit the underlying cortical regions through supplementary motor area has been helpful in OCDs, whereas high frequency RTMS of more than 5 Hz to enhance the cortical activity. There are studies which are done with RTMS over dorsolateral prefrontal cortex, which showed no significant improvement. All these are double-blind RCTs over right dorsolateral prefrontal cortex. Only one study by Ma et al. With alpha frequency match, it showed a significant improvement with p-value of less than 0.01. RTMS over supplementary motor area, the good evidence with 1 Hz frequency of 1200 stimulations per day. There was Manto et al. Study and Gomes et al. Study, both are double-blind randomized controlled trials, which showed significant improvement in both active group and which persisted after 14 weeks of study. RTMS over OFC, the hyperactivity of orbitofrontal cortex is more consistently seen in OCD. 2 studies which support this with a significant improvement in active treatment by Ruffini et al. And Nossi et al. Coming to TDCS, it consists of applying a weak direct current between 2 electrodes placed on the scalp. Depending on the electrode polarity and current intensity, it may decrease or increase the cortical excitability in the vicinity of anode, whereas cathodal TDCS may decrease it. Anodal TDCS or supplementary motor area, based on imaging studies, reveals that an interaction between pre-supplementary motor area hypoactivity and deficient response inhibition with reciprocal striatal in patients with OCD. Targeting dorsolateral prefrontal cortex on NABS studies reports beneficial clinical effects. There are 2 cases with pre-supplementary motor area stimulation. Both had forbidden thoughts, with both being SSRI non-responders, and there was significant Vibox score improvement in 3 days. The figure shows significant greater activation during the no-go condition compared to the go condition in the left pre-SMA, corresponding to Brodmann's area 6, and after adding on TDCS. This is from Narayan Swamy et al. Study. This is a network study which shows the cathodal placement and anodal placement. All these studies are with a very small sample size, with number being 1 or 2, but the latest study by Nazafi et al. In 2070, which is an open label study with Vibox score decreased by more than 63%, and the maintenance of effect after 3 months of the follow-up. So it could be speculated that hyperactive corticostriatal pathways in OCD may be downregulated by either inhibitory stimulation of the OFC with cathode or by excitatory stimulation of dorsolateral prefrontal cortex with anode. There is one more open label study with TACS, that is transcranial alternate current stimulation, applied at 40 Hz gamma frequency with decrease of OC symptoms by 52% on Vibox. Coming to neurosurgery, anterior cingulotomy, capsulotomy, limbic leucotomy and subchoroid tracheotomy are being performed with an improvement in OC patient, resistant OCD patient. It's being tried with 50 to 60% improvement. Significant improvement is of about 30%. The only concerns are the improvement is not seen immediately after surgery, and there are personality changes with surgery, and there is no control data. Deep brain stimulation is a novel technique which is successfully used in Parkinson's disease. The advantages are being non-ablative, adjustability, and possibly RCTs are possible. This is published in Ablative Neurosurgery and Deep Brain Stimulation Studies, published in IJP in 2019 by Shyam Sundar Armugam sir and Srinivas Balachandar sir. So to conclude, treatment resistant as two non-response to two SSRI trials. Clomipramine can be tried, venlafaxine and CBT. If there is no response, again with clomipramine, CBT, ERP plus SSRI plus an antipsychotic. IV clomipramine can be tried with clonazepam and other antipsychotic as being the augmenting agent. Even then, if we can try other SSRIs. Finally, the surgery and DBS. I will conclude with novel interventions which are being used these days for OC patients. The electron health-based assessment using smartphone and the digital version of a validated scale such as Vibox, ecological momentary system and administration of psychological questioning via internet for screening and monitoring of symptoms, web-based screening question via Vibox. The advantage of this is it is free from recall bias and allows the patients to keep an accurate diary of their symptoms and behaviors. VR-based assessment, though it is costly, it refers to immersive, interactive, multi-sensory, 3D viewed, computer-generated environments, and these combination of technologies is required to build these environments. We have no specific study stating that VR-based assessment is beneficial in OC patients. There are 5 studies for machine learn-based system for treatment response and symptom severity. One is Salmon et al. Study with 130 participants using SSRI alone, and SSRI with risperidone, and 3 variables: Vibox, neuropsychological performance, and epidemiological data to predict treatment outcomes at 3 and 6 months. So this Maas et al. Study applied to supervised classifications that included structural MRA and diffuse tensor imaging and genetic data to predict early onset OCD severity. And other 5 studies also have found that machine learning perception to have a considerable and better predictive performance. The other is being biofeedback based intervention. The advantage is it is painless, non-invasive procedure. Consists of capturing biometric data such as EEG, ECG, EMG and skin conductance. There is a study by Surmeli et al. Where EEG guided neurofeedback in a case series of 36 treated resistant patients of OCD with 91% participants showed a clinical improvement according to Vibox and CGI. Thank you. Thank you for patient hearing.
Thank you, Dr. Vasistha, for your detailed and well-researched presentation. Yes, we know that OCD is a disabling disorder, illness. Regarding its course, it has a waxing and a waning course. And probably brain stimulation is will be mainstay of treatment in the future. Over to the house for questions now.
Vasistha, I think wonderful presentation. Thorough. Last 10 to 15 years of research. You summarized the imaging, clinical aspects and the therapy. I just want to focus on just one aspect. We are doing in our center the neuro stimulation RTMS. In fact, my most recent paper was this year. It's published only in February. What I thought I would tell the audience is RTMS has 3 models. One is a classical slow model which used to be the practice. See the total amount of stimulation, simple stimulation. Second is premotor stimulation of 3 to 5 minutes before with a added dose, and then give again a dose spreading over 2 weeks. There is a third one which we started, and I'm in touch with Narayan Swami also. That is the accelerated approach, in which we give for 5 days to 7 days, daily 3 to 4 sessions. What we found in treatment-resistant OCD especially, and that's what is published in the recent paper, was at least 40 to 60% improved who are considered treatment-resistant. That is, they had 2 SSRI, 2 different SSRI or SSRI with SNRI trials of at least 8 weeks. It's actually, we took 12 weeks actually for in this paper which we published. The take-home message is RTMS has to be very carefully weight to be given on the right side. Better, and I think the consistent emergence of one fact is premotor stimulation on the non-dominant side is going to help. Thank you, because I thought I would emphasize this. This is our center is one center which we are working along with NIMHANS, and I think the data would be coming little more. And we actually won the ASHA AABP award last year, 2 years back. Thank you.
I'm Uday Kumar. Very informative and lucid presentation, Vasishtha. You have covered most of the things. I just want to add one simple issue here regarding comorbidity of OCD. The Indira Sharma, one of the ex-IPS presidents, was presenting a paper about OCD. She gone on proving that OCD is depressive spectrum disorder. OCD is none other than OCD belongs to depressive spectrum disorders, and she was asking us to carefully observe depression being the one of the best associated disorder in the OCD, and then asking us to be very careful about the clomipramine being the tricyclic antidepressant, because we give a lot of importance to clomipramine, and which is causing OCD to mania. So she was finally concluding that OCD is nothing but a depressive spectrum disorders one. So I think be cautious about using clomipramine in OCD. Thank you.
Any more questions? Regarding antipsychotic augmentation, aripiprazole also has been advocated. Regarding it is said that antipsychotics do result in OCD, but what I read, if it is given in low doses, it helps, it has beneficial effects, but in higher doses, it may produce OCD, like clozapine. Clozapine-induced OCD has been seen. Noted. So if there are no more questions, I think we'll close the session. Thank you all.
Thank you. Thank you, ma'am.
Thank you, ma'am. Thank you, sir. I request our chairpersons to present the token of appreciation to our speaker. I also request our speaker, Dr. Vasishtha Garu, to present the token of appreciation to the chairpersons. Thank you, sir. Moving on to the next session. Autism, early identification and newer advances in neurobiology. I request Dr. Minaz Jafar Nasrabadi and Dr. Nitya Murthy Garu to come onto the stage and chair the session. I also request Dr. Rishikesh Giri Prasad Garu to come to the stage and present his session. Dr. Minaz is a professor and HOD Department of Psychiatry, Deccan Medical College. He is recipient of A.K. Nayak Award for Best Paper, has many publications to his credit in various national and international journals. He was the Honorable General Secretary, IPS Telangana South Branch, Honorable General Secretary, IAPP, Telangana State Branch, Convener Media and Mental Health, Convener Media and Mental Health IPS Subcommittee, is a co-chair Events and Subcommittee IAPP Subcommittee, recipient of National President Award IMA 2017-18 and IMA Telangana State Award 2020 and 21. Dr. Nitya N. Murthy garu she did her MD and PDF in MA Psychology, and she was a visiting consultant at Rainbow Hospitals, Banjaras and Kondapur. Now I hand over the mic to the chairpersons to introduce our speaker.
Thank you. Thank you. Hello? Mic. Can I get a mic? Dr. Rishikesh Giri Prasad, he has done his DCH, and after that, after completing his DCH, he has joined MD Psychiatry from Osmania. He is Assistant Professor in Child Psychiatry, Department of Child Psychiatry, Nelofer Hospital. He has conducted various workshops on early screening methods in autism, awarded as Young Speaker from IPS South Zone 2018, trained medical officer under RBSK and NMH programs on child psychiatry and POSCO Act. More than that, I would like to introduce Dr. Rishikesh as a very good bowler and batsman from our team Telangana. Also, I keep on hearing about Dr. Rishikesh from my students at Deccan Medical College, and they have lots of praise for you, Dr. Rishikesh. Congratulations. I would like Madam to introduce the topic.
Thank you, sir. It's indeed a privilege and honor to chair the session by Dr. Rishikesh, who is an eminent speaker by himself. I've heard his sessions. And the topic is very relevant for today, that is early identification and early diagnosis. And early intervention in autism has been shown to have sustained gains in children in the long run. Up to 6 years after stopping early intervention also, we are seeing a lot of benefits in children. And there have been tremendous advances in neurobiology, neuroimaging, and understanding of genetic architecture in autism. So we would love to hear you out, sir. So you can, I transfer the session to you.
Yeah, thank you, Minaz sir, for the nice words, and Nitya ma'am. Before starting my session, I'd like to thank the organizers, especially Prasad Rao sir for giving me the opportunity, and Dr. Sri Lakshmi for recommending me about this topic. And you all know autism is a neurodevelopmental disorder which is very confusing to diagnose at early age. As we grow on, probably we can diagnose, but at early age of diagnosis is very important for early intervention so that the outcome is very poor. In the Western countries, what we know is once the child is diagnosed autism, he's lifelong autistic. He'll be given all the provisions there in Western countries. But in India, it is not like that. It is still have to be, the government has to make a program about recognizing the autism children and has to provide a special program and special training and attach a special educator for them. That's why in India, early recognition is pretty important so that early intervention will help the children to not to lag behind the other children. So I'll start my presentation. It's about DSM criteria. You all know the DSM criteria, how to diagnose autism. It's basically because of the current or the history, there should be all the 4 criteria it should be met, A, B, C, D. A, B is about persistent deficit in social communication and social interactions across all the contexts. And it should not be because of general development delay. And all the 3 manifestations should be present, you diagnose. That is basic deficit in social emotional reciprocity, deficit in non-verbal communication behaviors used for social interaction, deficits in developing and maintaining relationships, and restricted repetitive behavior patterns, interests and activities manifested at least 2 of the following, which include stereotyped repetitive movements, both motor and use of objects, and excessive adherence to routines, ritualized patterns, verbal or non-verbal behaviors, excessive resistance to change, highly restricted and fixed interests that are abnormal in intensity or focus, or hyperactive to any stimuli. These are the diagnostic criteria which are present, which should be present for diagnosis, for diagnosing of autism, and the criteria should be fit, which should be perfectly fit for diagnosing a case of autism. And to say diagnosis only done by after 2 years of age, but suspicion can be done as early as 1 month of age and can be as early as it is. And you can tell the risk of the patient, whether it is low risk, medium risk or high risk, based on different questionnaires and based on your observation. And the symptoms which are presented start at early childhood and should be more than the expected. It should not be lacking in the expected age of mental ability of the child, and there should also be impairment in function should be present. So this is basically the diagnostic criteria. To put it in a simpler way, so impaired social communication, which includes social and emotional reciprocity, where the child will not be able to have that social ability to communicate with the parents, not only with the parents, to the outsiders, to the family members, to the brothers, to the cousins who are in the family, especially initially with the family members. What I have noticed is the autistic children are initially very communicative with the parents, especially with the mother. They try to communicate, but far lesser extent than what the age of communication should be there. That's why the picking of this illness is very rare. Now, about coming to non-verbal communication, as the age grows, the child should have non-verbal communication where there will be gesturing, pointing out and asking for things by different gestures. Still he did not develop language. There will be deficit in non-verbal communication also, as well as verbal communication. And also there will be difficulty in maintaining relationships. They don't understand. They know he is a father and he is a mother, he is a brother, but they don't understand the importance of the relationship and the importance of communication and importance of social emotional reciprocity. And other domain is repeated restrictive behavior patterns. It can be both motor and verbal stereotypes. Motor stereotypes includes flapping of hands, doing the same thing on and on, repeated playing of similar activities, not engaging in imaginative play, or repeated motor speech activities, verbal activities like saying some jargon words or repeating the same words continuously throughout the day, or picking up some word on that particular day and doing it same and same. And excessive adherence to routines. They are very difficult to change and difficult to adapt to a new situation. They are actually adapt to the same situation. I've seen kids where they want the same plate to eat, same type of dress to wear, continuously for a week, for a month or 2 months, and they want to do it same and same. That is basically adherence to the routines. And there is difficulty to change in routines. And restrictive interest. Interest will also be very high about eating patterns, the color of the food, the texture of the food. Everything is important for this child. And hypo and hyperreactivity to sensory inputs. Basically, there may be hyperacusis or hypoacusis when you go for hearing, hyperdynia or hypodynia when it is about the pain, or it can be the child sometimes complain of very high pain with small injuries and no pain when there is a large injury when the child is bleeding also. So all these are present in autistic child. The main component is impaired social communication and repetitive restrictive patterns. As it is a spectrum, there are many illnesses, and every child has different presentation, but the core symptoms should be present to diagnose the case of autism rather than all the other symptoms. Sensory issues are present in some cases, may not be present. If you are present, to be a lesser extent or more extent. But primary aim is only to have impaired social communication and repetitive restrictive patterns should be present. So for the early diagnosis, ASD at high risk infants as early as first month of the child, the biomarkers for this diagnosis is poor eye contact. When the child is trying to lift, the child will not be making an eye contact. Though he can't see the parent because of the visual blurring, the poor ability of visual acuity, because of the tactile or touch, or because of the blurred vision, still the child has to able to maintain eye contact, which will be lacking in autistic kids, and lack of effective reciprocity. When the mother tries to cuddle the child, the reciprocity will not be as prominent as seen in normal children. Atypical eye gaze behavior, where the child will be looking from the sideways at that age and not looking directly into the eyes, will be present. And lack of joint attention skills. Joint attention skills are something where when you are doing something, the child should be observing and try to do the same thing or imitate the same thing, which will be lacking in kids. So as early as first month, these will be developing. If they are not seen at this age, probably you can suspect rather than diagnose. So these are the biomarkers, and it is proven in very different studies, which I have given quoted below. And as per the American Academy of Neurology, autism can be diagnosed if there is no babbling or pointing out or other gesturing by 12 months of age. By 12 months of the age, if the child is not babbling or not pointing out, or any other gestures is not developing, probably you can suspect autism. No single words by 16 months, or no 2 words spontaneous words. No spontaneous words is child has to develop his own spontaneous words, asking or demanding things rather than echolalia. Most of the children will have echolalia. They repeat whatever the parents say or the teacher says or the therapist says, but they can't have their own spontaneous words. If it is not developing by 2 years of age, probably you can suspect autism. And loss of language skills at any age. So initially loss of language at any age of skills should be suspecting autism. There can be other problems where there will be white matter to grey matter recession. Initially social speech and language will be gone, rather than motor milestones will be lost. But in this case of autism, only there will be social and speech will be lost. And I have seen cases at losing at the age of 7 or 8 years, which diagnosed under atypical autism. So loss of language at any age should be suspect autism. So what are the clinical features? I want to dive clinical features initially about at the first year life also, because we only diagnose or look into autism cases by 2 or 3 years of age. I want to show the clinical features which are present at as early as possible. So divided into different domains like social interactions, communication, and everyday behaviors. What you see in first year of life? Limited ability to anticipate to pick up. Most of the children, whenever they see the mother or father, they give their hands to ask them to pick up. But this will be lacking in these cases, or if it is present also, it will be to the lesser extent. Low frequency at looking at the people. These children, when the people are walking around, or when the mother is walking around, the tendency to look towards the parents will be very less. Little interest in interacting. When the mother is trying to interact with the child by giving different toys, rattles and everything, they show very little interest at first year of life. Little affection towards the family members. They don't always, as you see, the age of first year of the life, below first year, most of the child will be clinging to the mother, holding to the mother rather than separating from the mother. But this child will show little affection towards the mothers, and they try to be alone most of the times. They will be content with their own self-stimulatory behaviors like holding a rattle in the hand or sucking or doing something else rather than trying to be with the parents. And at the second and third year of life, there will be abnormal eye contact. The eye contact will not be maintained continuously. Some parents say that they maintain eye contact, but which is not continuous. The continuous eye contact is something where they should be maintaining an eye contact when you communicate with the child continuously. But this will be lacking. Though the eye contact is there, if it is to the lesser extent compared to the age of the child. Limited social referencing. They can't have a social point of view or social talking, engage with the friends. And limited interest in playing with other children. Like they always play alone. They don't mingle with other children. When I ask the parents, how you see your parents when you're left with the child? They say that they mingle with the parents. But it's not mingling. They run around the child, they hold the children, they push the children, but they don't have the interactive play with the children, which will be lacking. So this question should be very specific when you're asking to the parents. Most of the parents think that playing around, running around the kid is a playing, but it should be interactive game with the other child, which will be lacking in these kids. Lack of social smile. Definitely social smile is very, very less or limited. Somebody may smile at times, somebody may not smile, but compared to the age, it will be little lesser. Lower frequency for looking at the people. When the new person come at the home, children tend to see the parents and ask indirectly that who is that person coming to the house. But this will be lacking. When the parents ask the child to say hello or hi, they can't say it, they can't repeat it, the gesture. That's why which will be lacking in autism kids again. Limited sharing of affect and enjoyment. Whenever the kids what I have noticed is whenever they play something and they do something, they do a task or they complete a building block, they're building a Lego, they try to call the parents and show them what they have did, which will be lacking in autism kids. Lack of range of facial expressions. If they are present also, they are very limited. They can't express their face. Most of the times there will be flat face. Parents say that, yeah, my child cries when I shout at them. But the range of emotions they showed in different situations will be very limited. And unusual attachment to the objects. So they're obsessed with objects, the kind of objects they're obsessed with. I've seen kids with or objects with dustbins. They're rather than toys and everything, they're obsessed with dustbins, toothpaste, hairpins, hairbrushes. They keep on holding in the hand and running around them rather than toys itself. Limited interest in interactive games. Then the parent try to do an interactive game like one-on-one games or including other people's also. There will be very limited interest. And limited functional play. Functional play is something where you have to apply your mind and do something which will be less compared to that age group. And no pretend play will be there. When the parent try to imitate something and ask him to do the same thing, which will be lacking in autism kids. And limited motor initiation. Most of the cases, there are two types of autism that are described. There is hypoactive autism and hyperactive autism. In hyperactive autism, there will be more motor activity, but the imitation will be very less. In hypoactive autism, the imitation will be little higher than the hyperactive autism, but not up to the extent of the age. And social interest may increase over the time with passive interaction. Passive interaction is something that the age grows, there may be social interaction. So I see in a point of view, social interaction is something, it should not be retained to only family members, it should be to the community as the age grows. If you're talking about a 4-year child, the social interaction is not limited to the parents. It should be beyond the parents, to the friends, to the relatives, everybody. But this will be less. And what is passive interaction? Passive interaction is whenever you ask the question, they reply it or they do something rather than they coming and asking them. So they don't have the active interest to participate in a discussion, active interest to play. It's only the passive interaction which is present in the 2nd and 3rd years of life. These are the most prominent features which are present in 2nd and 3rd year lives, and most of the cases are diagnosed at this age. And coming to the communication, delay in acquisition of languages are more frequently present in complaints of the parents. The parents usually come with complaints of saying that my child is not speaking. They have speech delay. So why this thing is common in parents? Why can't the parents notice that the child is not responding to the call, child is interacting with us, child is playing alone? The parent's point of view is that occasionally the child will respond to the name, occasionally he will do whatever parent says. So this fluctuation of presenting in each individual is very different. That's why it's very difficult for the parents to pick up those points. They only look at the language point of view, the speech point of view. And I have seen kids who can speak in mean ways. They can say rhymes, they can say alphabets, they can say colors, but they don't use working language like amma, nana, tata, akka. So all these things are the complaints usually the parents come with. What happens in the first year of life? Poor response to the name. The first primary complaint, most of the parents say that he doesn't respond to the name when I call the name. He doesn't listen to me when I call his name. But in sometimes they respond. Occasionally they respond. The parents think that as he's responding, as he's busy, that's why he's not responding. But at the age of 1 year, whatever may be the situation, if you take 10 situations, at least 70 to 80% of the child will respond to the parent's call. 30 to 40% will be the response in these cases who are with autistic or at high risk of autistic. So the response to the name is very limited. Infrequent looking at the objects held by the others. When the parent try to make him look at the object or a toy which is brought in yearly, there is no interest in looking at it, or if it is looking also, the infrequent looking will be there, or it will not be interested in the toy. Poor gesturing and non-verbal communication. And communication is not about just only social communication and verbal communication. It's about non-verbal communication also. As you see the development course of the children, initially there will be non-verbal communication like pointing out, gesturing and all those things, which will be lacking in autistic kids, suspected autistic kids in first year of life. So in second and third year of life, what happens with the symptoms? So low frequency of verbal and non-verbal communication, so not appropriate for age. If they are there also, they are very limited communication. Failure to share interest like pointing, showing and giving and sharing the objects. Failure to respond to communicative gestures. When you asked, this is the predominant question I ask. When you tell the child to bring something, he won't do it. If he does it also, it is very occasionally he does it. This gives me a clue and or make the parents understand that probably there is a problem. They come with the complaints of speech delay, but when you say the parent, whether your child does something, when you ask him, they say no. That makes the parents think that why he is not understanding. So that's one point where you can actually tell to the parents what could be the reason that he is not understanding. Either he should be deaf, he is not understanding, either there is some other problem, that's why he is not understanding. And failure to respond to communicative gestures, that whenever parent is trying to show something outside or interesting thing, the plane going outside, the truck going outside, he'll be very less interested, very least interested. If he's seeing also, he don't know why he is seeing. Usage of other body as tools like object usage, where they point out, they use different mechanisms to make the parents understand what they want, will also be lacking. Unusual vocalizations will be present. They are called jargon words. Sometimes they pick up jargon words. Once they talk also, it will be a monotonous language without any prosody or anything. And they produce different kind of words. Most commonly, birds chirping kind of sounds will be present in these cases. Echolalia may be present once the speech develops. Echolalia is something, they repeat whatever you say. Something like that, when you ask their name, what is your name? They say, what is your name? Then you say, what are you doing? They say, what are you doing? It's only repeating rather than answering the question, understanding the question and answering back. No duet communication. Duet communication is something, there should be to and fro communication between the parents and the child when they're talking on something else. This will be lacking in autistic kids at second and third year of life. Less flexible speech with poor pragmatics. What is pragmatics? Pragmatics is about social communication, usage of language according to the social situation, which also will be lacking in these kids. So other component is stereotypical and repetitive behaviors. Children with ASD have difficulty in tolerating to change and various routines and attachment. There is poor adaptability once they change from one place to other place. So whenever you are giving therapies, or whenever I tell parents to do things about therapies, I tell them not to change the places frequently, to keep the environment, structured environment that should be continuously maintained, so that child will not go into distress and they'll be more cooperative for therapies and what are the treatments you are giving. What happens in first year of life in stereotypical words? Excessive mouthing will be there. Mouthing is usually normal phenomena at this age. Whatever you give, they'll keep in the mouth. But in autistic kids, there will be excessive mouthing. Continuously, the only gesture they are showing is mouthing. Whatever you give in hand, whatever they have in hand, or the hand itself, or mittens itself in the hand, they keep on mouthing itself. So excessive mouthing will be present. And aversion to social touch. When mother tries to pick up or hold the child, they'll cry, they'll become cranky, they move their head, they try to hit. Everything they do it in first year of life. So aversion to touch is also one of the prominent features in first year of life. In second years, vocal stereotypes will be there, as we discussed previously. Vocal stereotypes are something where they doing some sounds and running here and there, which doesn't have any meaning. Motor stereotype is like flapping of hands, jumping at one place, rocking movements, rotating in one place, lining of objects, all these things will be there. Echopraxia will be there, and unusual sensory behavior where there is a picture depiction that if it is a cold outside, but he does not wear, he is not interested in wearing a warm clothes. He'll be more comfortable with the normal clothing. If there is a heat outside, it's very warm outside, he prefers to wear warm clothes. So unusual sensory behavior can be there in these kids at second year, third year of life. So there are 3 levels of functioning of autism. Level 1, level 2, level 3. Level 3 requires support. Level 2 requires substantial support. and level 3 requires very, very substantial support. These are the base of diagnosis given by Nelson, and there are different diagnostic criteria by different tools: mild, moderate, severe, low risk, medium risk, and high risk based on the evaluation. This is the most prominent thing where you can see that in level 1, difficulty in initiating social interaction, organ planning problems can hamper independence. So based on this, actually you can plan where to start the therapies, where to intervene. This will help you to understand the child, where the child exactly fits in and what therapies will be helpful. So diagnosis, how do you diagnose? Most of the times it hits history, what you get from there. It's a chronic, longitudinal history from before birth, how it starts, what is during the delivery, when something happened during the delivery, prenatal, postnatal, natal, all these things should be put into the history, and observation of the child while he is in clinic, or the playroom, what you have, how the child is behaving, all should be noted. And after that, you have to compare with the criteria what you have in ICD-10 or DSM-5, probably will give you a diagnosis. If you want to give a corroborative evidence, there are tools like infant-toddler checklist, which can be done as early as 6 to 24 months. It will give you a risk rather than diagnosis, how much the risk is there. These are very easily available online. Psychology Tools is a website where you can just log in the website. It will give you a questionnaire. You can enter the details. Based on that, you get a scoring, and it will give you the risk of the child. And same thing with MCHAT, review and follow-up. MCHAT is a modified checklist for autism. It can be done between 18 to 36 months. There are two components in this. MCHAT review is something we do it once the child walks in. And once the child has low risk, medium or high risk can be given based on the scoring. Low risk can be followed after 1 month. Medium and high risks should be immediately started early intervention. If you still have a doubt, you can do a follow-up questionnaire of MCHAT, which gives you much more clues for closer to giving a diagnosis of autism. And CARS 2 is the one which can be used about 2 years. It's a Western questionnaire, very easy to do and very easily applied. And ISA is the one which is developed by NIMH. Now it is called NIEPD. Which is called Indian Scale for Assessment of Autism. It is done about 3 years, and ISA is used for certification for government programs for Sadram rather than CARS. So ISA is very easy to do. It requires very small tools. It has 4 domains, and questionnaire is there. You can ask questionnaires, and easily available online also. You can get it as a PDF. You can read how to do it. Once you do it, you know the level of autism. Based on that, you started the interventions. Coming to the newer advances of neurobiology in autism. So, autism and genetics. Autism is highly highly heritable as well as heritable also. So, highly heritable, where this shows by twin studies which have done. So, twin study shows that heritability is around 0.7 to 0.9% of incidence. In monozygotic twins, it ranges up to 30%, but in dizygotic, it can be between 18 to 20%. So, the heritability is pretty high. In first degree relatives, if you see the probands of autistic, it may not be autistic, but the behavior of autistic, like speech delay, less communication, all these things can be as high as 25% high-fold risk may be present in first degree relatives. When we do a chromosomal structure abnormalities by whole genome DNA microarrays, you can see submicroscopic and microscopic anomalies rather than major microscopic anomalies, rather than major chromosomal abnormalities. This is why there is difficulty in diagnosing autism. This is why where we can't see what is the reason for autism. There is no single reason for autism. The heritability, everything will be very different in each and every child unless the child is having some syndrome. A study by Sabat et al. And Marshall showed that de novo copy number variation deletion is the most common finding and has as high risk as 10% of ASD cases have these copy number variations, especially deletions are present in these cases. And recurrent CNVs like duplication of chromosome 15q11 and 13, duplication and deletion of 16pq11 and deletion of 22q11 and 13, each accounting for 0.5 to 1% of cases. So this gives a proof of there is a heritability of this. Autism is pretty high when there is a deletion of copy number variations. 10 to 20% of children who are ASD with low IQ or dysmorphic features have some genetic lesions. As you see, tuberous sclerosis, all these cases are very high risk for autism. So there is a genetic risk. You can identify actually the genetic component when there is a low IQ or dysmorphic features. Study shows significant genetic association between CLA in the promoter region of MET receptor tyrosine kinase gene. This MET receptor tyrosine kinase gene, what does it does? It basically helps in remodeling the tissue, proliferation of the tissue, especially in the brain, in neocortical areas. It also affects the immune factors. It also affects the gastrointestinal system. So all the features which are present in autism, like poor communication, bad bowel. Most of the kids have bad bowel with constipation, loose stools, and bad false smelling stool. And the immune system, where most of the children with autism have allergic symptoms like rash, allergic sinusitis. They are more prone from all these allergic conditions. This explains everything. This is the one theory which explains everything, including all the systems. This MET receptor, tyrosine kinase gene receptor, where CL is associated with it. The strongest association is noted in families when there is more than one kid is affected. 2 copies of CLR gene are noted when there is more than one kid affected. This gives much more evidence about genetics of autism. Coming to microcephaly, autism and microcephaly, most of the patients or clients what have a microcephaly. Head circumferences in most of the cases 90th percentile, observed up to 20% of autistic children, especially in the mid-childhood. This proliferation usually does not occur at birth. As the age grows, there will be a post-growth acceleration will be there. The brain overgrowth pattern is aged is important, most prominent in frontal lobes, anterior temporal lobes, and also involves interconnected parietal areas. There is a theory saying that the large microcephaly is because of improper pruning. Pruning is something where the axons and dendrites are connected in a particular manner, but because of improper pruning, there will be erratic growth of pruning, increasing the brain matter, leading to a microcephaly. The abnormalities in brain structures include both gray and white matter, which involves both short-term and long-range connections between brain regions. The short-term connections are still very short. Long-range connections are become long, but they are very little. That's why there will be deficits in all the areas. Electrophysiological studies showed reduced size of corpus callosum, which connects two cerebral hemispheres. In this, long-range connections are deficit when it is there. Reduced cerebellar connections with other brain regions is also present. These are all short-range connections which are present. So there will be both intrahemispheric connection deficit and interhemispheric connection deficits are present in autism, which is leading to these kind of behaviors. Evidence of reduced functional structural connectivity between frontal and temporal lobes also found. That's what I was talking about. Both intra and interhemispheric connections will be deficit in autism kids. So autism microcephaly, this is a diagram which gives you that the yellow area, which is a white matter extending into gray matter, erratic extension of white matter can be seen into gray matter with thinning of the gray matter, but other structures which relatively look normal. So autism and pathological investigations. Several studies showed decreased in cerebellar Purkinje cells in ASD cases. Bailey and colleagues who performed an anatomical study on 6 brain showed subtle deficit in cortical organizations. We all know there is a deficit in cortical organization, but this subtle deficit is known when there is a postmortem studies done in these cases, especially in frontal cortical mini-columnar organization. What are mini-columns? Mini-columns are something provide fundamental block for cortical information processing and changes in cortical microarchitecture. Mini-columns are something very small areas which bind together to form a macrocolumns. They are of receptive field which are deficient in different areas of cortex, causing the deficiency about all the communication and social and emotional reciprocity. So these form a group of things which are very deficit. They are present, but to a lesser extent compared to the area of normal people. A recent serological study showed that there is a lesser size of amygdala, which is for emotional regulation. So that's why the emotional regulation in autism kids is very poor. Probably this is the reason why it is poor. And this is the picture showing the amount of microcolumns. In the first picture here is a normal kid. You can see the amount of microcolumns which are present. They are very thick and very close. But in the second thing with autistic kids, there is a much gaps can be seen in that area. So the lesser number of microcolumns are present. So there are other theories which are there. I thought the time will not be limited for this. There are if the time is permitting, then probably I'll add some other theories which are useful, which are under hypothesis. There are theories like mirror neuron systems. Mirror neuron systems are something where when you see somebody acting or doing an act, the passively these mirror neuron system which are present will be getting activated, and passively doing the same action in the mind will be present. These will be deficit in autism kids. That's why there will be poor imitation. This is one theory which is coming up. Other theory is theories of mind, where the autistic child will not be put himself into others' point of view, cannot think from others' point of view as an empathetic point of view. That's why he will not be able to understand what the others are thinking. Whenever others say something, he doesn't understand why he said it, but he takes the meanings literally rather than understanding what is behind what he said. There are other studies which show that the dysfunction of gamma and GABAergic systems, which are both excitatory and inhibitory hormone systems. That's why the hyperactivity, because of this dysfunction, that the hyperactivity is noted in these kids. Because of this higher function of gamma excitatory neurons, and inhibitory effect of GABA is very less. That's why there is a hyperactivity which is seen in GABAergic and glutaminergic system. And oxytocin theory is also very much propagated, where oxytocin helps in emotional bonding, happiness, and creating the reciprocation and emotional bonding with the people, which is also lacking in these kids. And other things are about melatonin, which is also deficient. As most of the kids of autism will have sleep disturbances, most of the kids have a delayed sleep or a disturbed sleep. Melatonin may be deficient in these cases. That's why whenever I get a case of sleep disturbances, rather than giving any benzos or clonidine, melatonin will be a better option to supplement, which definitely improves the sleep pattern of the child. And other theories which say that hypothalamic pituitary axis theory, which controls stress in children, which controls stress, this axis has an abnormality. That's why the children are more prone for stress. They have a poor adaptability. Once difficulty in changing, they are prone for easy stress whenever there are small changes in their routine, which cause the distress in the children. These are some other hypotheses which are there but not yet proven. Coming to the summary, it is a syndrome, not an etiological defined disorder. The term autism spectrum accommodates less severe form of autism and wide variability of clinical presentation. This says that there are wide presentation. As the age grows also, the presentation will be varying more and more varied because of the external environment stimulation. That's why epigenetics also plays a major role. Because of the exposure of the environment, the child stimulation. If there is an autistic kid, if there is a very good stimulation, the kid may be picking up very better way. If the autistic kid, same kid, is not having proper stimulation or an environment to pick up, he may not be picking up in such a way. That's why the presentation is very varied presentations are there. So at least in most of the case of autism, when we assess a developmental quotient or social maturity scale, most of them will have IQ more than 70, does not fit into mild intellectual disability. There may be borderline intellectual disability. That is because of poor social communication and poor social reciprocation rather than other activities. They basically have a very good rote memory, and their intelligence sometimes in Asperger's, if you take, the intelligence is pretty high. But because of the lack of social reciprocation, they fall into borderline criteria. The risk of autism with genetic is almost between 70 to 90%. Genetic mutations causing autism can be identified in 10 to 20% of patients by current methods, especially from CNVs, copy number variants. No single genetic mutation account for more than 1% of ASD, showing a heterogeneous presentation. So there is no single genes for saying that this may be a cause for causing autism. There are multiple genes. So whenever somebody asks, can we go for genetic testing? Can we go for this testing? I say no, because there is unnecessary expenditure about that. If I find a clinical feature or a dysmorphic feature or a feature which is suggesting there may be a genetic predisposition, then only I'll ask my patients to go for genetic testing rather than wasting money on genetic testing. No unifying pathology has been identified in autism, although the brain changes can be seen in frontal lobes and anterior temporal lobes, which are replicated by different MRIs, but which are also not very consistent in all the cases. Fewer cases have some abnormality, fewer cases did not have some abnormalities. So That is the reason we are not sure about how much it is affecting the autism children. So what are the further issues? What can be done to do this? There should be a large clinical studies and cohort studies should be done, including control and autism kids. There should be a control people and autism kids. Age match control should be given, and all the investigation should be done, including genetic analysis, imaging, all these things. Then only you will know what is exactly reason, what is the neurobiology going on behind. This is probably the future advances where we can do, because there are more and more fMRIs we are doing. This research will help you to know exactly what is the reason, what is the neurobiological reason behind causing the autism. And about the neuropathology, autism neuropathology, serological anatomical study shows the biochemical, cellular and molecular investigation in large group of postmortem studies. These elements helps you to identify the neurobiology of the autism kids. So the more postmortem studies you do in autism, the better knowing of how it is there. So the better understanding of neurobiology of autism will be there. Probably this should be promoted more and more. Many investigators are currently working on what are the biomarkers for early identification of autism, but still they are yet to know what are the basis of doing studies, where to start, and what the subtype should be done, what exactly is to be done. There are the further guidelines where we can do to know exactly, understand how the autism goes, and once you diagnose autism, therapeutic intervention at early stage will help you to improve autism very well. More validated and accepted animal models should be also produced, which can be used as a study purpose, so that we can understand how it is exactly working, not only neurobiology, how the drugs are working, how the therapies are working, how everything is working. So animal model should be introduced where experiment can be done and more to see and understand autism. So autism, to conclude, autism is a very wide range of presentation of disease. As you delay more and more, the treatment will be more and more difficult. And from the parents' point of view, if you see at them, that the burden of the parents will be very difficult. I feel managing an intellectual disability kid will be very easy than managing an autism kid. You know, autism kids can learn, but still we can't do anything. You know, intellectual disability kid is already has a damaged brain. We can't do much about this kids if there is a severe or profound. But in autism kids, if the intelligence is little fine, you can actually make them into a position where they can survive their own. So autism should be given more priority and should be done more and more research studies, especially in India, so that you can understand the illness and treat it very well with early intervention, as early as 9 months or 1 year if you see. And to give you an example, my sister-in-law, my wife's sister-in-law's child is autistic, which I suspected around 15 months of age, but I took time for convincing them. Around 18 months I have to start the early intervention. Now the child is around 2.5 years old child, without any therapies. The only mother did all the things. Now he's speaking sentences very fluently, and he's studying, he's writing. So you pick up early, you diagnose or suspect early, you start early intervention early, the chance of becoming the child near normal is very, very, very high. So by this end, I'll end the presentation. Thank you.
Thank you, Dr. Rishikesh. Wonderful presentation, extensive presentation. I would ask Dr. Nitya Madam to add one comment. We'll close fast because we are running out of time.
Thank you, sir, for simplifying a complex topic, and you have stressed upon the heterogeneity of presentation, the varied presentations of autism, because of which it could be easily missed in children. So it is very important for us professionals to be trained in identifying autism. And yeah, with that, we will close the... Sir has...
Sir, please.
Rishikesh, a fairly interesting and a comprehensive presentation. Thank you for that. One of the aims is, I think, as you said, autism, there was always a conflict. Who will own autistic disorders? Is it we, the psychiatrists, or the developmental pediatrics, or the neurologist. My own feeling is these skills, whatever you have presented, has to reach to all the psychiatrists, especially the young psychiatrists sitting here. I would suggest that you being in, you can say, double specialist, child specialist and psychiatrist as well. I would like you, through the Indian Psychiatric Society, Telangana State Branch, take a small groups of these students, at least devote once in a week or once in 10 days webinar. Today, world, anyone would sponsor, or through Ipstsb. Impart this with a case veneer. See, as you presented so much beautifully, you need to show to them. And just like dementia, I take the example, two extremes, child and dementia. See, diagnosing dementia anyone can make. Diagnosing autism anyone can make, especially after some stage. But how to intervene and what to go. And I want you to take a little bit of leadership along with the child psychiatrist of our group. I think I would also request the President of Indian Psychiatric Society, Telangana State Branch, and the current leadership to consider that we'll have a specialty child psychiatrist group who would impart especially the CMEs and active therapists. And thank you, Rishikesh. I know you are a great cricketer, but I would like you to play well in child psychiatry too.
So as Prasad Rao sir already mentioned, there are three groups trying to own this autism. Even in the name of developmental pediatrics, pediatricians are trying to own this, all child psychiatry issues. Even the neurologists also, they are trying to own this one. So we have to, as Prasad Rao sir already mentioned, we have to conduct repeated webinars among the postgraduates to bring awareness regarding this diagnosing and administering the scales, identifying all the symptoms. Though we have to do some webinars regularly, because then only our own people will come to know this subject is ours. Thank you.
Thank you, sir. Dr. Pawan.
Thank you, Rishi. Wonderful presentation. I guess Rishi is both pediatrician and a psychiatrist, so it will be a dilemma for him to take sides. So my question is, after starting the early intervention, suppose if they get well, say 18 months or 16 months we start early intervention services, they are near normal. At what period should they be really followed up for re-emergence or any other things? Thank you.
Sir, definitely I take the psychiatry side. So now, being a pediatrician, I'm more of a child psychiatrist than a pediatrician. So to coming to your point, sir, therapies, once we start therapies, we see usually improvement. What I usually do is, I do a repeated assessments. There are different questionnaires for assessment, both for parents and the professionals, like autism treatment evaluation checklist. A tick is available where you know to assess how much improvement is there for every 2 months. Based on that improvement, we plan therapies. So what happens in autism is, everybody is given OT, speech, ABA, OT, speech, ABA. But every child is not of same domain. So we have to know which areas improved, which areas not improved. There are 4 domains to look at: social, speech, sensory, behavior. So all these 4 domains you have to assess repeatedly and to know what therapies have to be given after the early intervention. Once the child becomes near normal, what I tell them is not to stop abruptly. You have to make it, if the sessions are weekly once, make it weekly 3 times, then make it weekly 2 times, make it weekly once, then every 3 months, then every 3 months, every 6 months, then stop. If you abruptly stop, definitely child is going to regress. I had a case who became near normal, and we thought of stopping the therapies. Once he stopped, in 15 days, relapsed back again. Then we have to go to the literature back and study about what exactly has happened. So gradually tapering the therapies will help them to understand the child, whether the child is coping up or not. So that gradual tapering probably will be more better option than abruptly stopping it.
Thank you, Rishi. We conclude the session.
Now I would like to request chairpersons to honor the speaker. I also request Dr. Rishikesh. Also request Dr. Rishikesh to present the token of presentation to our chairpersons. Thank you, sir. Moving on to the next session, bipolar disorder, concept of mixed episode. I request Dr. Pawan Kulkarni Garu and Dr. Shrikant Garu to chair the session. I also request Dr. Shanti Mohan K to come onto the stage and speak about this topic. Thank you, sir. Dr. Pawan Kulkarni Garu, Professor and Head and Department of Psychiatry, Chalmeda Anandrao Institute of Medical College. Was a consultant psychiatrist at Sri Ram Hospital, Karimnagar. His area of interest was consultation liaison psychiatry. He was the Honorable General Secretary for IPS, Telangana State Branch. Dr. Shrikant was a consultant psychiatrist at Osha Hospital, Civil Assistant Surgeon at District Hospital, Sangareddy. I am handing the mic to our chairpersons to introduce our speaker. Thank you.
Hello. At the outset, I would like to thank Dr. Prasad sir for giving me this opportunity, and it's my honor to chair a session. And today's speaker is Dr. Shanti Mohan, and he is also my friend, my UG classmate. We are from 2007 batch from Usmania Medical College. And he has done his MD in psychiatry from All India Institute of Medical Sciences, New Delhi. And he is the recipient of Poduvu Chinnareddy Venkatramamma Award for Best Research Paper in TS Psycon 2019. And he has presented his research work in national and other international conferences. And he is currently working under NMSP program for Medchal Malkajgiri district. And he is currently practicing at his own clinic at Suraram. And with this, let me hand over the further proceedings to Dr. Pawan sir.
I thank, at the outset, I thank the organizers for having us here. And I welcome Shanti Mohan. Bipolar disorders, mixed episode concept. He is presenting the topic on bipolar disorders, mixed episode concept. At the outset, it may appear very simple, but still mixed states do possess a challenge, pose challenges because of the wide polymorphism in its clinical features. So I am sure Shanti Mohan would be enlightening us how the concept and various concepts regarding bipolar disorder mixed states. Over to you, sir.
Thank you, sir, for your kind words. Respected senior faculty and consultants and my colleagues and all the So I will be presenting under these headings. So I'm going to discuss under these headings. So coming to introduction about the topic. Before we proceed about the mixed episode, we are all familiar with bipolar disorder term or the definition that it's a mood disorder characterized by episodes of depression along with mania or hypomania with inter-episodic remission and with the restoration of functioning. So as we are all aware that bipolar disorders, they are the 17th leading most cause of disability worldwide, and suicidal 6 to 7% of these population they do commit suicide, and the suicide rates are 20 to 30 times higher in bipolar disorder patients when compared to the other population. So we can understand the burden of bipolar disorders. And these bipolar disorders are classified varyingly by the different researchers. And we are all familiar with Achilles classification, which takes into consideration about the background affective temperaments and the course of episodes, how they occur in the longitudinal course. So I'm just giving briefly about the Achilles classification. So we can see here that they have been classified into 6 types predominantly. First being the full-blown episode, 1.5 being depression with protracted hypomania, then with hypomanic episodes. 2.5 deals with the depression and with the background of cyclothymic temperament, whereas the bipolar type 4 is depression with hyperthymic temperament. And bipolar type 3 is hypomania because of switch due to antidepressants. 3.5 is because of the substance use itself. Bipolar 5 is recurrent episodes with dysphoric hypomania, whereas the 6th one is late onset depression with mixed features, mimicking like that of dementia. So we are all familiar with this classification. So it's based on the background temperament and about the course of episodes they are presenting. What about those episodes wherein the symptoms of opposite polarity also occur within the same episode? How do we classify them? How do we diagnose them? How do we assess them? And how do we treat? So that is what I'm going to discuss. So let me give you an example or a case vignette how these kind of patients they present with us. We are all familiar with these kind of cases. We have often seen our in practice also. Let me give an example which is a case report which is being published already a long time back. So a 60-year-old patient who is a diagnosed case of recurrent depressive disorder with a current episode being a severe depression without psychotic symptoms. And the current episode lasted for 5 years duration. And as I mentioned, it's a severe depression. The patient has all the major criteria for depression. And in the current episode, patient had 3 suicidal attempts, which are very severe, and they required hospitalizations thrice. The family history being positive, and in the treatment history, in the past episode, he was being given with antidepressants, and in the current episode, also the same antidepressants were started, like nortriptyline 50 mg, bupropion 350 mg, metazapine for 45 mg. As there was no response, he was also initiated on venlafaxine, which was built up to 150 mg, then quetiapine and lithium. He also required multiple MECT sessions for the current episode because of his resistance picture. Then, as the patient was not responding, but however, on detailed further history taking, it was revealed that during his suicidal attempts in the current episode, before these suicidal attempts, there were some other symptoms like insomnia, pressured speech, goal-directed activity, flight of ideas, agitation and irritability lasting for a few days. And 2 of these occasions, it was noted that there has been an increase in antidepressant dose just prior to suicidal attempts. So, and you know how this patient responded because being a treatment-resistant depression. So, on discontinuing the venlafaxine medication in the current episode, the patient started improving. And he maintained well for the next 3 years just on lithium and quetiapine. So, diagnosed as a recurrent depressive disorder, but the patient improved after discontinuing the antidepressants. So, that is one interesting case. That is how these patients present. So, this is a case you may think that, but how often these kind of cases we often see? How frequent they occur in the general population or in the mood disorder? So, let's see. So, after going through this case, one might have some other queries like, what exactly happened to this case? Why did this patient did not respond? Similarly, the authors also have some queries like, were antidepressants simply ineffective because he has been tried on multiple antidepressants, or did they actually contribute to treatment resistance? We have some hypotheses stating that prolonged use of antidepressants do contribute to treatment resistance. Further, did actually antidepressants they led to hypomanic symptoms? Did the switch happen here? So that is one query. Or some evidence says that antidepressants do contribute to some suicidality, like black box warning sign being given to most of the antidepressants. So let's see how frequent or how prevalent they are in the general population. A systematic review I have chosen this one, which has taken almost 17 articles published till 2017 which have tried to look for the prevalence of these symptoms in mood disorders, like in major depressive disorder or bipolar type 1 and type 2. And the criteria which they have used to diagnose a mixed symptom is either DSM-5 or at least 3 symptoms from the opposite polarity. And these are the all articles, and we can see here that in the major depressive disorder, the mixed symptoms, they are almost 20%, 23%. And in the bipolar depression, they are up to 35%. And the same is the case with bipolar mania or hypomania. So we can understand how prevalent they are in mood disorder patients. At least 1/5 to 1/3 of the mood disorder patients are having simultaneous mixed symptoms also. So so how did this concept evolve? So let's see from the beginning. So the concept of this mixed symptoms or mixed episode, it was given by it dates back to the heritage of Cappadocia. Then August Henroth classified multiple types, different physical illnesses and mental illnesses as exaltations, depressions, and mixed states. Further, mixed states of those categories were subclassified as mixed mood disorders, mixed mental disorders, mixed volition disorders. Then we are all familiar with Kriplin's concept that he noticed that within the mood disorder patients, there are 3 specific domains. With respect to 3 specific domains, the symptoms are fluctuating with respect to mood, thought, and psychomotor activity. And accordingly, he classified 6 subtypes among the mood disorders, and that he proposed that they will present as either with a depression with flight of ideas, excited depression, depressive anxious mania, unproductive mania with poverty of thought, inhibited mania, and manic stupor. We can see here that along with the index symptoms, there are contrapolar symptoms. So he classified as 6 subtypes. He then only proposed that mixed states represent severe form of bipolar disorder, which is very true even in the current practice. Further, his colleague Vega, he for the first time published about the same concept on the mixed states of manic depressive insanity, and he introduced the term agitated depression. So till this time, the concept took its pace. It was going in a very good pace. But however, after when the Snyder came into picture, he stated that there is nothing, or he believed that there is nothing like mixed states, and he said that these are nothing but cyclothymia which are manifesting like mixed states. So there it took its pass about this concept until when the Vienna research, they have did their extensive research and they have hypothesized about the concept of mixed states. And they have got with some biological evidence also at that time. Then again it took its pace. Then let's discuss about the nosology. Then it came into the DSM. In the DSM 1 and 2, it has got no specific criteria. It will be labeled as mixed manic and depressive reaction other. Whereas in the DSM 3, for the first time, it has got its place, bipolar disorder mixed type, with the criteria being they have given that the episode should fulfill the criteria for both manic and depressive episodes, and there should be interchange or intermix of these symptoms. And at least for the 1 day, depressive symptoms should they should last at least for 1 whole day. In the revised revision, they have also given importance for the time duration. They propose that at least for the 2 weeks, these kind of symptoms should be there. In the DSM-4, they have retained the same criteria that the patient should meet symptomatic criteria for both mania and depression. However, the time duration, they have reduced it to 1 week only. And they further say that it is applicable only to type 1 bipolar disorder. So it's not attributable to substance or medications. However, in the DSM-5, the concept of mixed episode has been removed, and it was replaced by mixed futures and as a subtype. So it was not given any independent diagnosis in DSM-5, but to be included as a subtype under index manic or depressive episode. So as per the DSM-5, for mania or hypomania with mixed features, for the index episode of mania or hypomania, all the criteria should be met, and at least 3 symptoms from the opposite polarity should be met to diagnose it as with mixed features. And there should be an objective evidence and variation from the baseline as reported by the family members and not attributable to substances or medications. And this is something which has DSM-5 has included, the D criteria. If the symptoms meet full criteria for both mania and depression simultaneously within the same episode, then the diagnosis should be mania with mixed features. So it has been chosen or proposed like this because given the severity of mania and the dysfunction which is more with that mania, they have proposed that the preference should be given to mania. The diagnosis should be mania with mixed features rather than depression. Similarly, for depressive episode with mixed features, the index episode should meet the criteria for depressive episode and at least 3 symptoms from the opposite polarity. And again, the objective evidence should be there from the family members. And again, if the patient is meeting criteria for both mania and depression, the preference should be given to mania. The diagnosis will be mania with mixed features. However, DSM-5 has come with some new concept that it says that one should exclude overlapping symptoms while we are considering at least 3 criteria from the opposite polarity. And these overlapping symptoms are distractibility, irritability, psychomotor agitation, and vegetative symptoms. DSM-5 says that because these symptoms can be there in mania as well as depression, so we cannot take these symptoms into consideration. Like distractibility can be there in depression and as well as in mania. Irritability can be there in the depression like in agitated depression as well as it can be present in the mania. And neurovegetative symptoms may vary even within the mania as well as within the depression. So they say that they lack the specificity, hence they should be excluded from the diagnosis. So I already discussed the differences. So the name DSM-4 has given the independent diagnosis, but in the DSM-5 only as a subtype. And as per the DSM-4, it's only applicable to type 1 bipolar disorder. But as per the DSM-5, it is applicable to type 1, type 2, and major depressive disorder. This is one area which is being criticized for the DSM-5. As per the DSM-5, if the patient is having major depression along with at least 3 criteria for hypomania, we can label it as major depressive disorder with mixed features. But we are all familiar that in our practice we often see that if patient is presented with major depression and with some hypomania features, we are a little scared that the patient is probably in the bipolar spectrum. But here DSM-5 still entertains that it should be diagnosed under unipolar depression only. So that is being criticized. So the other one is exclusion of overlapping symptoms. So the other, some people have criticized the DSM-5 that we cannot exclude overlapping symptoms, and they have come with their evidence stating that, for example, psychomotor agitation in the depression is ranging from 16 to 35%, whereas psychomotor agitation is almost more than 90% in manic episodes. Hence, psychomotor agitation should be a characteristic feature of mixed mania, so we cannot exclude saying that it's an overlapping symptom. So some people criticize that overlapping symptoms should not have been removed from the DSM-5. So in the ICD-10, it still retains, it has given an independent diagnosis that it's a mixed episode. If it is single mixed episode, it becomes other mood disorder, it goes into other mood disorder classification, that is F38. And as per which it says that there should be a mixture of mania, hypomania, and depressive symptoms within the episode lasting for at least 2 weeks. And if the same episodes they recur, then the diagnosis, it goes into the bipolar spectrum and with the current episode mixed. And here also the time duration is being 2 weeks. So ICD-11 has, in the beta draft, they have given some criteria and how to diagnose. These are similar, the symptoms and the characteristic features are similar to that of ICD-10 only, and even the time duration is also 2 weeks. However, they have given some other specifiers kind of things in the ICD-11. They state that the mood state should be very altered throughout the episode, like that of acute transient psychosis. It should vary from depressed to dysphoric to euphoric to expansive. So, contrary to ICD-10, ICD-11 is going to say that additional details about contrapolar symptoms also, like that are similar to that of DSM-5. However, ICD-11, it states that mixed episode should be given only to bipolar type 1 diagnosis. So as it is not yet published, so again this will be criticized again because it is more close to that of DSM-4 only. So the one thing ICD-11 it is going to do is it has removed the number of, it has removed that at least 3 criteria, at least 4 criteria required, but it says that predominant symptoms should be from the index episode and common contrapolar symptoms it has given. Like if the patient has to be diagnosed mania with mixed episode with mania, the contrapolar symptoms at least should be there from the opposite, but it doesn't mention how many are required. And along with this, ICD-11 is also going to entertain about specify that about the course of illness, severity, psychotic symptoms, melancholia, comorbid anxiety, and about any perinatal onset. These are all it is going to entertain ICD-11 like that of DSM-4 or 5. So let's discuss about the neurobiology of mixed states. As of now, we do not have any robust evidence from the neurobiological point of view, but whatever the evidence we got, let's discuss. So coming to the animal models, they have seen that on olfactory bulb, surgical removal of olfactory bulb in some of the animals, those animals behaved with symptoms similar to that of mixed states, like that of decreased copulation and decreased locomotion and some of the manic or hypomanic symptoms. And it was seen that these behaviors, that mixed states, were related to alteration in neurotransmitter levels. They like increased serotonin in the prefrontal cortex, striatum, hippocampus, and decreased derivatives of serotonin in the nucleus accumbens. Further, they have noticed that whatever the changes are happening after removing the olfactory bulb, these are restored by giving some external treatment in the form of RTMS or something like that. And after giving RTMS, they have noticed that these symptoms are getting elevated. Thus, they hypothesize that olfactory bulb has something to do with mixed states. In the human models, we have some evidence for circadian rhythm disturbances and biogenic amines that they do have some role in mixed state concept. Circadian system, most of our psychiatric diagnoses, they are all linked to circadian system either directly or indirectly in the neurobiological systems. In the similar way, as here we can see that directly they regulate monoaminergic or dopaminergic pathways, and they also control the hypothalamic pituitary adrenal axis and hypothalamic pituitary thyroid axis through either directly through with the expression of clock genes or indirectly through some connections originating from the suprachiasmatic nucleus. So this is one of the hypotheses which states that, for example, in an euthymic patients or in a vulnerable population, if there, because of some epigenetic mechanism, if the clock genes are polymorphized, if the polymorphism of clock genes occurs, that leads to increased dopaminergic activity in all those areas, mesolimbic areas. That might lead to hypomanic or manic symptoms either in euthymic patients or those who are already suffering from depression. So if the patient is already in depression, but because of clock gene polymorphism, he may also have dopaminergic overactivity and he may also present with some kind of hypomanic picture, mimicking similar to that of mixed state. Similarly, sometimes even the recent evidence is coming regarding cholinergic pathways, which states that increased cholinergic activity in either euthymic population or in a vulnerable population can mimic symptoms which are similar to depression. So excessive cholinergic activity or by giving any medications which increase acetylcholine or cholinergic activity, they itself can induce or they can induce depression-like symptoms. So due to which even in the euthymic population or in vulnerable population, this mixed kind of pictures can happen. And circadian rhythm is slowed in depression and it's very faster in the mania. So some propose that in mixed state, it's a very transitional state where in the long term, it may either go into the mania. Further, the evidence says that we are all familiar with the seasonal affective disorders, wherein morning light therapy has evidence that in the treatment of depression. But in some vulnerable population, it was found that giving morning light therapy to these population itself induced mixed symptoms. However, giving the light therapy in the afternoon, it's not inducing, or it's not giving any kind of switch. Further strengthening that there is some role for circadian rhythm. From the neurotransmitters, we have evidence for monoamines especially. And one important point I would like to point out is that in either mixed mania or in mixed depression, these neurotransmitters levels are increased when compared to their index episode. One may think that because in the mania the neurotransmitters like norepinephrine, dopamine are increased, because in the mixed mania the patient is going to have some kind of depressive symptoms, so they should have been decreased. It's contrarily, in all the mixed episodes, the aminergic activity is increased. It's very contrary finding. And regarding the hypothalamic pituitary, also you can see here that in the mixed episodes, the activity is more compared to the index episode. However, we do not have sufficient evidence about the role of thyroid hormones as of now. Inflammatory components also, we have some role that the inflammatory markers are increased in mixed mania patients, but as of now we do not have any evidence for their role in mixed depression. So some have hypothesized that increased monoemergenic transmission leads to definitely some kind of behavioral symptoms like hyperactivation and hyperarousal, and they have evidence from the biological point of view. And they say that hyperactivation and hyperarousal symptoms, they have to be considered as core features of mixed episodes because they got bioimaging evidence also. So they propose that they should be considered as core features. But in the DSM-5, as I already discussed, that they have been removed that because these are overlapping symptoms. However, the biological theory or biological evidence says that these should be considered as core features. So this is again one area where the DSM-5 is getting criticized. That we are getting a lot of evidence that they are the core symptoms. So inflammation, as of now, we do not have sufficient evidence. Whatever the evidence is there, they have some limitations being the small sample size. And as of now, brain networks and thyroid functions, we do not have sufficient evidence, or whatever the evidence is there, it's very inconsistent. So I'm not going to discuss. So do we have any implications? So let's see. From the diagnostic point of view, we have some clinical implications from the mixed episode. So a retrospective chart review was done, which took almost all the articles on the bipolar disorders. A retrospective chart review about all the bipolar patients, which included 331 patients with a diagnosis of DSM-4. What they did was they reclassified all these DSM-4 bipolar patients as per the new criteria, that is as per the DSM-5 criteria. So they tried to see if there is any difference in the diagnosis of mixed episode. So as per the DSM-4, initially they have been diagnosed, but they again reviewed and they just reclassified. We can see here that as per the DSM-4, the prevalence of mixed episode in that population is 6%. But the same patients, when they are diagnosed with DSM-5, the prevalence of mixed episode, it is almost 20%. So the same patients are being, so the DSM-5 is able to capture better when compared to DSM-4. So definitely it's going to have treatment implications as well. So whatever the case we discussed probably might have missed in the DSM-4 as a depressive episode only, but as per the DSM-5, the diagnosis, it has been changed. However, some criticize about the diagnosis of DSM-5 also. They say that some of the pioneer workers like Kokopoulos, they say that removing overlapping symptoms or loss of agitation in DSM-5 means departure from the classic definitions. From the Kreplin's diagnosis system, it is considered that agitation should be a main part of mood disorder. However, removing agitation from the DSM-5 means we are deviating from the standard classification system or from the older concepts. Further, a study which says that every additional manic symptom in major depressive disorder patient has it increases the chances of being bipolar disorder by at least 24%. So symptoms from the opposite polarity, they always increase the chance of bipolarity in the long term. From the clinical picture, do we have any clinical pointers which say that if these pointers are there, the patient might probably have mixed state? So again, a cross-section study was done which tried to differentiate clinical features which differentiates mixed symptoms in bipolar disorder compared to without mixed symptoms in major affective disorders. Here we can see that mixed symptoms in mood disorder patients, these patients are going to have a higher past history of mixed episodes. They are going to have higher comorbid substance use. They are going to have higher switch rate, suicidal acts. They are going to have a higher separated family history. They are going to be unemployed and their family being separated. The family history of suicide, family history of bipolar disorder. These are all higher in mood disorder patients with mixed features when compared to mood disorder patients without mixed features. So these all indicate that whenever we come across patients with these symptoms, we have to keep in our mind that patient might probably have mixed episode also. Implications for treatment, as I discussed in our the case vignette itself, I discuss about the implications. So major depressive disorder patients with antidepressant induced switch, they are going to have higher treatment resistance, like in our case vignette which we discussed. They are going to have higher mood lability and irritability. And this point I come across, it states that major depressive disorder with mixed features, they carry the highest risk of suicide among all kinds of mood disorders. That might give a hint that the patient should be started on lithium at the initial point. So whenever we are dealing with mixed episode, we should always keep in mind that these kind of differential should always be kept in mind. Like major depressive disorder with borderline personality and with those comorbid substance disorder, especially these mimic hypomanic kind of picture. If they are in the background of major depressive disorder, that may mimic like mixed state. Even conduct disorder and occupational defiant disorder, and some other medications like dopamine agonist medications like levodopa and in the corticosteroids, we often see in the clinical practice that corticosteroids, they do induce some kind of mixed state of picture. And some of the neuropsychiatric manifestations in medical conditions, organic conditions like HIV, syphilis, they have to be kept in mind. So how do we assess? So we do not have any standard structured assessment to diagnose mixed states. But the one thing which saves everyone is history taking. Proper history taking, as we have seen in our case vignette, that itself will give us an evidence that whether the patient is also experienced mixed symptoms or not. So this is the same as the pointers for bipolarity in a major depressive disorder. So the same should be kept in mind while we are encountering any kind of these symptoms in patients with a major depressive disorder. We should always keep in mind that the patient probably might also have mixed states, or in the long term he might be going to bipolar. So this we have already discussed. We have some scales not validated in Indian population. So clinically useful depression outcome scale. This is used for assessing DSM for mixed specifier in major depressive disorder. It contains 13 questions. So each item is written on Likert scale from 0 to 4, 0 indicating not at all to 4 indicating almost all the symptoms of the opposite polarity are there. And the total score ranges from 0 to 52. It is useful in assessing over the course of time. So it doesn't quantify that if these many criteria are met, you can definitely diagnose. But over the course of the episode, it is useful for the assessment. And a mini module of for manic episode with mixed features was developed, which evaluates DSM by specified mixed features in manic or hypomania. It's self-rated, having good sensitivity and specificity, and having good or moderate inter-rater reliability. So as for this, there are 6 items. If the patient is scoring at least 3, then probably the patient might have mixed manic episode with mixed depressive episodes. So these are some of the other scales. COCO plus mixed depression rating score. It takes into DSM-4 as well as DSM-5. Then depressive mixed state and other standing rating scales like which we use in general regular practice, like for HAM-D for depression, that can be used to assess cross-sectionally the symptoms from the opposite polarity. However, none of these scales have been violated or structured in Indian population. Coming to the management, so as we have discussed that this topic is a little kind of volatile, whether it should be either into the major depression or it should go into the bipolar. So we do not have robust evidence from the management perspective also. So whatever the evidence we got from the management, we will discuss. For major depressive disorder with mixed features, Florida guidelines says that, so currently it has given 3 levels of evidence. It says that even the Florida guidelines says that we have got minimal evidence for patients with mixed features. It says to consider all the options, non-pharmacological and pharmacological options. It says that antidepressant monotherapy should be given for 48 weeks and it should be reassessed after 4 weeks. If there is partial response, we have to observe for next 2 to 4 weeks. And if no response, then adequate dose has to be given. And if there is no response, then we have to go to level 2. But it mentions that antidepressant monotherapy in MDD patients with subcentrale hypomania may be associated with a higher rate of suboptimal outcomes. So it only mentions this point, but otherwise it says that one has to treat like that of a unipolar depression, leaving about the switch rate and all those things. So if in the level 1, if the patient did not respond, then it says that to reassess for episodic hypomania or mania, then ensure optimization of the dose. Then if there is no further response, then go for lurasidone. And in the level 3, if there is no further response with lurasidone, it says that then to try for second generation antipsychotic which has got evidence, or lithium or lamotrigine. Then if there is no further response, go for ECT or RTMS. And if still there is resistance, then they say that just try for other alternative antidepressants like TCS or MAO inhibitors. We also have STARS guidelines, which says that if the patient is present with major depressive disorder with subsyndromal hypomania, it says that if the patient is on antidepressant monotherapy, then it says that to evaluate if there are symptoms from the opposite polarity or mixed features, and if so, they advise to stop it. And if still, and they advise to stop, then they advise to initiate an atypical antipsychotic. If there is therapeutic response, then continue as maintenance therapy. If there is no response, then they advise to either change the atypical antipsychotic or they try mood stabilizer. And if there is therapeutic response, then again we have to continue. If there is no response, then they advise that we can initiate antidepressant. After atypical antipsychotic or mood stabilizer, if there is no response, then they advise that one can start antidepressant. And if still there is no response, then they advise for ECT. And among the atypical antipsychotics, olanzapine, lurasidone, escitalopram, quetiapine, ziprisidone, they have got the evidence in treating major depressive disorder with mixed features. It gives caution that all patients who are on antidepressants for major depressive episode with mixed features should be monitored for abnormal activation or psychomotor acceleration. And they say that if at all we are giving antidepressants to major depressive disorder with mixed features, it is preferable to add alternative psychotropic agents like lithium or mood stabilizers along with antidepressants. ISBD and CANMER guidelines for mania with mixed features, it says that atypical antipsychotic should be used. So whatever we discussed, that atypical antipsychotic, the same were proposed by ISBD and CANMER guidelines. And they advise to use combination therapy if possible, rather than giving only atypical antipsychotic. For bipolar depression with mixed features, ISBD task force and CANMAT recommends avoiding antidepressants in patients with mixed features. Bipolar patients with mixed features, it is preferably advised to avoid antidepressants alone. The only medication which have got evidence is olanzapine fluoxetine combination, esanapril, lurasidone. So this is not from the guidelines, but a follow-up STEP-BD study, it was found that adjunctive antidepressants use did not reduce time to recover related to treatment with mood stabilizers alone. And adding adjunctive antidepressants was associated with significant higher mania symptoms at the 3 months follow-up. So even they advise to not to go for antidepressants in patients with mixed features. World Federation of Society for Biological Psychiatry, they have also come with their guidelines. They say that if there is an index episode of mixed episode acute in the acute treatment, they have say that ziprasidone has got evidence. If there is an index manic episode with mixed features, olanzapine or olanzapine plus valproate has got evidence. And to prevent the further episode of depression from an index episode or mixed episode, they say that quetiapine has gotten adequate evidence that it prevents future any kind of mood episodes if the index episode is mixed mood disorder. So IV ketamine, they have hypothesized that it might have a role, but as of now I did not find any study which has given IV ketamine for mixed state population. And recently, 1 month back, theta burst stimulation was also given. However, they did not find any significant role for theta burst stimulation. Non-pharmacological management, as of now, the current evidence says that non-pharmacological management have to be adjunctive and complementary to the standard pharmacotherapy, but it should not be used as a standalone treatment. And all the non-pharmacological management which are used in bipolar patients can be used, but it should be adjunctive and complementary. To summarize, DSM-5 has broadened the concept which makes it easy to capture early and assess early, and we can treat early. Circadian rhythm disturbance has a promising role of evidence from whatever the evidence we have till today. So mixed episode patients, they will have increased frequency of psychotic symptoms, increased risk of suicide, increased risk of comorbidities and rapid cycling. They are going to be presented at early age onset compared to other mood disorder patients. They have poor prognosis and they are going to have poor psychosocial functioning. For major depressive disorder with mixed symptoms, preferably add other efficacious psychotropic medications along with major depressive antidepressant medications. For bipolar disorder patients with mixed symptoms, ISBD task force and CANMAT recommends avoiding antidepressants. These are some of the useful references. If one has to go through, they can go through. Thank you, Marana.
Thank you. Thank you, Shanti Mohan, for a wonderful presentation. Now thank you, Shanti Mohan, for the wonderful presentation. Now we'll have quick questions, if any. If there are no further questions, we will end this session. Thank you.
Thank you, sir. I request our chairpersons to give the token to our presenters. So please collect. I also request Shanti Mohan Garu to give the token of presentation to our chairpersons. Chandresh, CV. Moving on to the next session. So, a topic about debate, mental health technologies, impact versus benefits. The chairperson for this debate is Dr. Chaitanya Deepak Garu. I invite him to the stage to chair the session. I also invite the moderator for this session, Dr. Naresh Vadlamani Garu, to come onto the stage and take the dais. The speakers for this topic is supporting this topic, Dr. Pani Prashant Garu, and against this topic, Dr. Lokesh Kumar Garu. I invite both of them to come onto the stage and take the sessions. Dr. Chaitanya Deepak, he was the director and consultant psychiatrist at hospital, runs an OCD clinic and obesity clinic at Asha Hospitals. Dr. Naresh Garu is the presented research papers for Bhagwat Award, ANSIPS 1999 and Young Research Award category at APA, Philadelphia. Main interest was suicide prevention, MHCA 2017 and critical appraisal of research articles, ESRD. Organized and conducted suicide prevention awareness 2K run, Hyderabad for the past 5 years, second Sunday of September in association with IPS, Telangana State Branch in HPS. Other roles, he was a national ex-EC member, representing South Zone IPS, ex-Honorable General Secretary, Indian Psychiatric Society, South Zonal Branch, ex-President, Hyderabad Psychiatric Society, ex-General Secretary, IPS, AP Comment State. He was ex-Chairperson, School Mental Health Committee, IPS, ex-Associate Professor, Bhaskara Medical College, Telangana, now Chief Consultant Psychiatrist at Columbus Hospital, a 30-bedded Institute for Psychiatry and Addiction, Begumpet, Hyderabad, currently Associate Professor, Apollo Hospitals of Medical Sciences, Hyderabad. Now I hand over the mic to our chairperson to introduce our moderator and speakers.
Good afternoon, everyone. So we are coming to the interesting debate of mental health technologies, impact versus benefit. I hope that it makes everyone stick back to the hall. We have two interesting speakers. One, my friend, Dr. Lokesh. He's an associate professor at Bhaskara Medical College. He received gold medal for his original research work on incidence of suicide at AP Psycon 2013 held at Hyderabad. He has 15 publications across various journals to his credit. The next speaker is Dr. Fani Prashant. He was my teacher back when I was doing DNB. He used to take case presentations for us. I'm glad that I can chair his session over here. He is director and consultant psychiatrist at Chaitanya Hospital, consultant psychiatrist at Care Hospital, and he is the first editor of Telangana Journal of Psychiatry. He has many publications to his credit and conducted and participated in numerous academic activities nationally and internationally. I think the debate will be starting with Dr.
We'll start the debate. Right. Okay. Right. Dr. Fani Prashant, he's a consultant at Chaitanya Hospital. He'll be talking about the use of technologies, mental health, technology in mental health, and he'll be speaking for the subject, that is promoting technologies. And Dr. Lokesh Kumar, he'll be speaking against the technologies. So I think the hall is nearly more than half full, and it is the last session. I'm glad that there are so many people in the hall. And I think after 1.5 years, let me tell you that 1.5 years I'm seeing such a conference, a physical conference. And I can say the feel among the people is that people are rejecting the technology of Zoom, of meeting. And they are so happy to be present here physically. So I think you can judge by which side I'm already biased towards. Right? But anyway, I won't give it away. But let us go on with the discussions. Dr. Fani Prashant, it's your talk.
Very good afternoon to all of you. I first want to thank Dr. Prasad Rao Garu to consider me to talk about this topic, and it's really nice to see face of people directly when you're talking rather than seeing a computer screen. That's really a good feel to start off with. But I'm going to be the protagonist here. Okay, I always believe in technology, and then it's easy to go towards the technology rather than against the technology in this growing age. So this is a cakewalk for me, looks like. But my opponent is going to have a tough time, to prove me wrong. Okay. So first of all, when we talk about mental health and mental illness, one should understand that there is a divide. Okay, we are not talking about mental health technologies only for mental illnesses like schizophrenia or depression or dementia. We are even talking about lifestyle changes, behavioral changes, personality development, emotional development. There has been a research on loneliness, which has shown clearly that if somebody is having loneliness, their likelihood of having mental illness is high and their likelihood of dying early is high. So even those areas where the mental health is supposed to be a positive thing, technology has taken a very positive step towards these things. So improving focus and concentration. So it's just not about mental illnesses, it's about mental health as well. But when we come to mental illnesses, the challenges we face as a daily or a clinician, is that first the diagnosis is mostly subjective. We don't really have anything to validate clearly that this is the finding and this is what it is and this is definitely this. Sometimes schizophrenia becomes bipolar, sometimes OCD becomes schizophrenia, sometimes schizophrenia becomes OCD. We really don't have gold standard definitive diagnostic tools in our hand to say, and it's mostly subjective. And how to predict a prognosis or a relapse or longitudinal course, it's a complex interaction between the environment and the family. So, and then controversies about whether to diagnose some behaviors as illness or not. Some child who is not studying adequately in school, he is not responding to family members, he is not socializing, but he is doing well at academics. Where do we put this guy? So these sort of issues which are there makes diagnosis in mental illness a little challenging, and we don't really have diagnostic aids at this point of time. We don't have any clear imaging techniques and diagnostic tests And psychometry, we do take help sometimes from our psychologists, but it's really not a gold standard diagnostic aid. And then patients are very guarded sometimes. They don't give you information about what you want. Sometimes over a longitudinal history, after 6 months, you see that somebody is reporting for auditory hallucinations. The golden period is already lost to start the antipsychotic by then. Okay, is there a way to monitor a person in his natural environment? Okay, so these are all the challenges which we have in psychiatry and mental health. And let us say this is one example to show how our measuring techniques are being used right now. This is one article which has come up which shows that measuring depression using various scales. They have taken up the most common scales which are used in research, and they found that only 12%, that is 6 symptoms overlap is there in most of this thing. The rest of them, there are almost 54 symptoms which are listed there. Only one scale has 40 items. Okay, only one scale has 40% of those symptoms. So what we are measuring sometimes is not clear as to, or a holistic. Somebody with this side 4 symptoms might be depressed, that side 4, but they're not similar. Okay, so there is a lot of heterogeneity in diagnosis as well in our clinical practice. Can technology come to our rescue in such situations? So with evolution of technology, I still remember when I was in my 10th class, I used to remember nearly 15 to 20 phone numbers, landline numbers of my friends and families and all. Now I don't even remember one. Okay, it's all basically because the friend which has come into our pocket has taken away our imagination, our memory, okay, our thought process to some extent, and it has substituted a lot of things, and it came with a lot of sensors. There are cameras, heat sensors, gyroscopes, where you are doing, how fast you are doing, how many days you are doing. So everything is being recorded for you without your knowledge sometimes and without your permission sometimes. Okay, you don't even give the permission sometimes, it's getting recorded. Okay, so this technology which has come up with, the sensors which are there, can it actually come up across along with the mental health issues like innovation, neuroscience, genomics, all computer science, come together and converge into one science and give us a lot of advantages? How data is being collected, there are different ways how technology uses the data. One is active data collection, where they take permission and then make you wear wearables which take data and then they come down. That's one way. Or passive data collection. You're not really feeding any data into the computer or into the device. It's automatically collecting how many calls you're making, how much time you're moving, how much time you're sleeping without you knowing it. Then there's a big data which has come up, like because there is a passive data collection, there's huge chunks of data which came up. Then this has been used through computational techniques and then what is called as machine learning. Sometimes machine makes connections which we don't see through our common eye. Okay, so that's machine learning will make projections and patterns. It is for us to decide which pattern is useful and which pattern should be used and which pattern is not really clear and which cannot be used. But there is something called deep learning which has come in the near future, which uses something similar to human mind through neural networks and then trying to find probable likely connections which are more clinically useful or relevant in a case. So this is how it comes. One, we are more looking at pathophysiology as a clinicians. Technology uses various sensors and puts that into data and comes to a formulation. So, but we have, as a clinicians, our main goal is to see the patient, identify the symptoms. But for a neuroscientist, he might be more interested in the circuits which are involved in the brain. For a technologist, what systems and computational techniques I have to use. And for the startups, it is the product. This product will sell, it is going to get me money or not. That is what. So the perspective changes in the science of development of technologies for mental health. So if you look at, there are startups which have come up in mental health have tremendously increased over years. If you see from 2014 to 2018 or 17, it's almost 3 times it increased. Okay, and most of these companies have come up with mental health apps or wearable devices or chatbots or artificial intelligence or assistive robots. Okay, so there are different types of varieties of things which have come up, and there are multiple. If you look at depression alone has so many mental health apps, like 500 to 1,000 mental health apps are available on the Google Play Store if you go and just find out. So these are the mental health apps which, okay, are there, which patient can download, they can utilize it. Okay, they might not be guided by a doctor, they can do it by themselves. So they provide, most of these mental health apps provide psychoeducation. Something went wrong. Oh. Most of them provide psychoeducation, they enhance the communication, they allow the patient to monitor themselves, they reduce the stigma that I am going to a psychiatrist or a psychologist for treatment. and then supplement. Even if they are going to a psychologist, it can supplement the therapy, or it can give additional inputs for the therapist. And patient empowerment. Like most of the patients who come now show me their sleep data. Sir, doctor, this is my sleep data. Then I find that he's sleeping at 2 o'clock and waking up at 11 o'clock. Okay, then the whole scenario, whether he's sleeping adequately or not, everything comes into play. So all these wearable devices and apps have made things easy. So when we look at different areas, I'm not going to details here. I'm just going to brush through what all the areas where the mental health technology has made a difference in mental health or psychiatry. So digital assessments, these are unique assessment tools which can have to be standardized definitely, but they can be using virtual reality or sensors or using games as a diagnostic tools. So this is the first of the thing, which is a game which is devised for ADHD. This has been approved by FDA as the first game to be used for children who have ADHD. It's called as AKIL. It was initially called Project Evo. They say that it improves concentration, and then utilizing this game for 2 hours to 3 hours in 4 weeks to 5 weeks reduces the symptoms of ADHD significantly. Okay. Then this diagnostic use using technology, how the patterns of how to identify autism. Autistic children who play through their iPads and all, the patterns which they make, the connections and the pressure with which they use the iPad, all these things have actually been able to utilize to predict autism almost up to 93% accuracy. That's very good actually according to me. So that's something which we can use. So there are digital assessments which are there, like from MSc, what we use as appearance, behavior, mood, affect and all what we generally do. Whether we can monitor them through some technology using some commercial examples, this is one place where it is possible is what it looks like. Predicting a relapse. Okay, somebody who's actually gone through a episode and recovered, whether we can predict the relapse early, very early, where the symptoms have not started. So there have been speech analysis, call logs, how many times you have logged and what way you've talked, what pause you gave. The speech analysis gives an idea as to a person is developing into this thing. They have been able to predict. And using sensors like impending aggression in an autistic child. If an autistic child is being sent to a particular room or environment, whether he is getting agitated, there are definite sensors which can pick up his pulse rate is increasing, his sweating is increasing, so he's likely to get into an agitated mood. So it can predict something like that. Or track symptoms of early relapse like sleep patterns which have been going where. Okay, or passive data collection, what you're not doing, you're not calling your friends as often you are doing, you're not opening your Facebook, you're not posting anything, you're not meeting your friends. All these passive data can also be used to predict a relapse. So technology and treatments, initially the main areas where the technology and treatments were there were virtual reality, robotics, avatar therapy in schizophrenia, AI therapists like called chatbots, which are called as. Okay, use of digital treatments, they can be either autonomous, like they can be independent or supported by the therapist, or blended digital, that is some programs which are run by universities or some research tools where they blend a part of the treatment as using technology. So VR treatment is first used most commonly in phobias for exposure therapy. This is some example where you are entering into a metro train, and slowly the number of people who are there inside, it becomes more crowded and crowded in a virtual reality. It's not realistic, but the patient is exposed. The patient is standing on the right hand side with the virtual reality thing on his thing. So as he gets more and more exposed, okay, so the likelihood of him getting exposed to such thing and relief of his phobias come down. So this have been very useful and proved to be very much useful in all the anxiety and phobia situations. But later we see that it's also useful for distraction of pain. Okay, how pain stimulus can be modified, or by training mindfulness or relaxation therapies, or even using other measures where you can actually take virtual reality. With virtual reality, you can monitor yourself as a different person, or you can see the response, what you are doing, how the other person is reacting. So in these models, okay, you are creating artificial environments where patient experiences emotions, behavior, and self-monitoring as well. So there are control trials for various psychiatric illnesses like anxiety. There is much evidence, very huge evidence, like 4 meta-analyses are there which state that they're definitely useful if used in conjunction with other treatments. Addiction, there is one control trials. If you're looking at autism, schizophrenia, depression. Okay, so even schizophrenia has 4 control trials. Okay, where VR social skills training improvement through VR, where cognitive and functioning and reduction of symptom was seen at 16 weeks, or cognitive functioning and self-efficacy was improved in one, and increased chance of obtaining a job and better job interviewing by role playing. Like you are role playing in a VR that you are attending an interview. Or with CBT, improved in persecuted elevation, convictions, and the real world distress. So there is evidence which is clearly coming up that artificial intelligence or the VR can be used effective tool along with your therapy or pharmacological treatments, so that it can be in conjunction. The autism, the brain power system, where this wearable eye device makes it augment the world so that the child sees up into the eyes, looking into the eyes, okay, and then smiling, getting into social skills training is much more easier with this sort of devices which have new optimism for autistic children. Okay, the social robots, these are mostly social assistive robots, they are called as. Okay, they actually are much more widely used in autistic children to improve the social skills training and then make them do some things, okay, in a structured manner without getting agitated and making them communicate well. These are also used in elderly. I think there is a huge morning big session on the elderly care with mental health technologies, but rehabilitation robots or socially assistive robots, which are more of companion type of service type. These are all useful in patients with dementia who can be assisted when they are living alone, or their agitation and behavioral symptoms can definitely be reduced, much like with companion robots or something like that, where they can be calmed and comforted very quickly without getting agitated and using psychotropics there. Okay, so these are some of the examples where the technology is getting into therapy. This is avatar therapy, where a schizophrenia patient gives face to the voices and then tries to softly tell the voices that they have to stop talking, and then that reduces the hallucination significantly, as what they found. It's very successfully treated. The similar thing is used for even borderline personality disorders, where they actually look at evaluate a situation more objectively rather than getting impulsive about the situation and getting anger. These are the chatbots which artificial intelligence is useful. The chatbot is called as Sensei. Okay, so this was first used for veterans in PTSD in America. This actually, the veteran is sitting in one place where the senses capture his movements of face and how his expression is. And then the chatbot or the artificial intelligence actually moves like an actual therapist and gives appropriate responses for the person, okay, without actually getting in touch with the therapist. Okay, so these are some things which are being developed and they are being utilized. Okay, the most common thing all of us must have experienced during like lockdown is that we were able to reach out to our patients very easily through the technology. That is what was telepsychiatry. Okay, there was a lot of apprehensions about telepsychiatry, okay, whether we should use them or not. Since the last 5 years, this topic was been going on. And then telepsychiatry is the most convenient and cost-effective way of making mental health available to most remote areas of the world. Okay, it has risen multifold during the pandemic and lockdowns. It's really given a helpful tool for most of our patients to prevent a relapse, follow the treatment, continue the treatment in spite of not having a physical visit. And it helps us also to reduce the infection rates without getting into the OP. So whether it is in practice, yeah, both the SCARF and NIMHANS have telepsychiatry units, and SCARF has a mobile unit which goes to the villages to do this. It's not new. It's not that we have not used it in the past. Okay, but there's a lot of apprehension from the clinicians to use it because of a lot of other issues, practical issues, whether technology is, some patients are able to use the technology appropriately, whether you're able to reach the right patient, whether it is safe. This HIPAA Act is what is the Information Protection Act, which was Insurance Protection and Accountability Act. This is the act which is used in the USA to protect the data which you are using while you are recording a patient or seeing a patient. All the recording is definitely secure and it is not going through different servers, okay, where it can be seen by others. So one has to be clear as to what sort of a patients you are selecting for this, and whether you are wanting to see somebody who is new, who have never seen, for the first time you want to see them or not. This is something which we will have to discuss and decide about. But there are other regulatory and legal issues associated with telepsychiatry. Who is whether the clinician has license, whether this license is visible in the thing or not, you are reaching a right therapist or not, you are just going to anybody who is claiming to be a psychiatrist or a psychologist. Okay, whether you can prescribe scheduled X drugs on online or not. All these things, credentials, malpractice insurance. Okay, so finally what I want to say is that if you choose your patients appropriately and use the technology adequately with pure security, this is a beautiful tool. 5 minutes, it's over. Okay. So there's some unanswered questions, whether diagnosis made through telepsychiatry and the real visits, is it regularly, is it right or not? Or whether we should be actually more relying on physical visits than virtual visits. There is no research on these areas. Adherence, there is one system where the pills are associated with the app, or there is a DMS system, digital medicine system, where you put a sensor inside the aripiprazole tablets and then swallow. And there is a sensor which tells you whether he has really swallowed it, how many times he has swallowed it, sort of a thing. So it can improve your adherence, and FDA actually gave a green flag for these things as well. So most of the patients found it convenient to use these tablets. It was not very difficult for them. So this is something which we can see in the future maybe. Are we digitally ready? That means, is there a digital signature for mental health? Okay, or we are going to see digital phenotypes rather than genetic phenotypes or other phenotypes in the near future. This is where we are. So finally, coming to the merits, it's very convenient. Patient has the anonymity and a different unique way of introducing of care. The patient doesn't need to come to a psychiatrist or get labeled that he's seeing a psychiatrist or a psychologist. It's lower cost, service to more people. It is 24 hours present for the patient. It is consistent. It is more objective rather than subjective or therapist associated, and it's proven to be effective. So with these and the final, if there is a fear that robots are going to replace human doctors, I don't think psychiatry is somewhere where they can do that. Okay, you need a psychiatrist to have that fine skills. Okay, and then it is more of a subjective as of now, the science. So that is not, and we can definitely work together to benefit the patient much more. And then this is where I rest my case. I now give it to it.
Thank you, Dr. Fani Prashant. I think that was a wonderful talk, brilliant, with all the aspects of technology covered. I mean, starting from the various devices that can be captured the information, the big data, he has gone through the big data, he has gone through what can we do with that big data, the diagnostic criteria and the symptoms, how can we capture so much of information. And then gradually he has even shifted down to the treatments. I mean, the various virtual reality treatments and various aspects of the illnesses that can be covered. And finally, he has just summarized it very well. Congratulations. But the winning is not yet over. The second half is left, the second innings. Right, I will invite Dr. Lokesh Kumar to go on and present his case.
A very good afternoon, everyone.
Take off your mask if you want. Yeah.
I would like to start my presentation with this paper clipping, which was posted in our Hyderabad Psychiatry Society group about a week or 10 days back. It states that a man uses mental health app for blackmail. For those who have not thoroughly gone through this paper article, I would like to narrate the story in brief. So there is a mental health app called as Talk Life, which is meant to serve mental health requirements, especially in South Asian countries. So a guy named Bharadwaj, he enrolled into it. So he started searching profiles of the women who were from poor socio-economic background, and he tried to trap 15 women, out of whom 3 fell prey to him. So he started messaging them on WhatsApp, telling them that he would support them financially, giving them at least $200 to $300 every month if they send their nude photos to him. So it happened for a month, and after that, here comes the twist. So after receiving some photos and videos, he started blackmailing them that he would upload all the photos which he already has onto the internet if they don't send them more number of photos. So then the victim has approached the police, and then the police started investigating the case. So the police have found out some interesting facts once they went to Bharadwaj's home. So when they spoke to Bharadwaj's father, He said that Bharadwaj was mostly preoccupied with the mobile phone, and in the past 6 months he has come out of the room only twice. Even food and water has to be supplied to his room, and he never came out of the room himself. So when you are hearing this story, practically are you able to relate this to your own clinical practice? Maybe once in a fortnight or once in 20 days, at least we get 1 or 2 parents to us who say that my child is completely preoccupied with the mobile phone. He's absolutely not coming out of the home. He spends most of the time in his room isolated. His social relations are disrupted. This is the regular story that we tend to hear once in 15 to 20 days. Yes, right? So with this background, I would like to proceed. I'll be talking about the demerits of mental health technologies. I'm Dr. Lokesh Kumar, working as an associate professor at Bhaskar Medical College. So this is how our journey is going to proceed. First, we'll have a brief introduction. Then we'll talk about various platforms to share mental health issues. Then we'll talk about demerits from patient's view. We'll talk about demerits from doctor's point of view and demerits from technical point of view. And finally, we'll summarize the issue. Yes. Before I proceed with my talk, I would like to confess one thing. Using so much of technology like laptop, mic, then PowerPoint and all, I'm here supposedly blaming the technology itself. I would like to confess for it. Second thing is, my talk is not going to be so scientific because if I start speaking scientifically, indirectly I would be supporting my colleague. So that's the reason why my talk will be mostly on the practical aspects, that's it. Okay, how people are getting affected by the technology. I will not be talking about all the scientific research and all. So let us go through the presentation. Yes, undoubtedly, technically we are growing so much and so fast. But the thing is, as far as our mental health is concerned, are we regressing? This is what is the question. So with excessive use of technology, are we regressing? This is what is the question. There are so many platforms to share mental health issues. I will not be going into all the details of the platforms. But practically, do you think that most of the people are using these platforms to share their emotional things or anxiety-related issues? No. You have seen so many WhatsApp status like this, like I feel alone. Have you seen any? You must have had your friends who must have posted like this status, right? I feel alone. Then sharing emotions is not just restricted to mental health apps. It is also shared on WhatsApp status, Facebook status, and all. Yes. So this is an interesting study which was done in 2018, which found out that if you go through the study, this is a study which talks about topics teens post about on social media. So this has not included any mental health app. It is mostly on WhatsApp, Instagram, and Facebook. So if you see from bottom, they have posted accomplishments first, then family-related matters, and surprisingly, the next 3 are emotions, dating life, and personal problems. So most of the people are unaware of so many mental health apps. They are posting their emotions and personal issues on social media platforms, and this has become a platform from where they can be victims. Any guesses what these are? Gang of Ganja Heroes and Kings of Smoke. These are the names of 2 WhatsApp groups. Yes. So when a cannabis abuse patient has come to me, I just wanted to inquire where he is getting from. So he showed me the WhatsApp group named as Gang of Ganja Heroes, and out of 51 people, there were 3 women in it with different names. And all of them, they turned out to be victims in some way or the other. So not just the mental health apps, even WhatsApp and Facebook, they have become platforms to share the mental health issues, and from where they can become the victims of men. Right. So let's see issues from patient's point of view. First, most important thing is, as of today, as far as awareness about the mental health is concerned, we are lagging behind so much. We need to admit that Babas, Mullahs, and priests, they are seeing more OP when compared to so many psychiatrists sitting here. Yes or no? Yes, we have to agree. So at least as of today, we need to focus more on spreading the awareness when compared to introducing technology into the people. Well, even if they have a mental health app, even if they know that there is a mental health app, they have a problem with with the knowledge how to use. Even maybe those people who have, the young people, probably your parents might not be knowing how to use a WhatsApp and Facebook itself. So probably it could be difficult for them, for those elderly people to use a mental health app. Obviously, privacy is the biggest issue. So this is again another article which says Hyderabad woman was trapped on social media confession page. So it seems that there is a confession page which is on Facebook and Instagram, which students maintain. Again, this woman was hijacked from this social media platform, knowing about her mental status. The other issues from patient's view, first thing is emotional connection. We always need to understand that talking to a person is a far more different thing when compared to talking to a laptop or a system. Yes, talking to a person makes a huge difference when compared to talking to a laptop or a system. So the emotional connection between the patient and the doctor will definitely be lacking as far as using any mental health app is concerned. Then, as we have already discussed, definitely addiction is one of the major issues once people start using any technology app. Okay, then obviously, as we have gone through in the first slide itself, and we tend to experience even during our clinical practice, excessive use of technology will definitely lead to disturbed social relationships. Yeah. So the last point, but not the least, there is something called as technology-induced psychological issues. With the advent of these kind of smart watches, at least once in a month or twice in a month, we tend to get some patients who regularly keep monitoring their sleep pattern, who regularly keep monitoring their pulse, who regularly keep monitoring their stress levels and all. So those patients, especially who are suffering from anxiety disorders, with a small surge in heart rate, the next day they come, doctor, yesterday night I slept only for 4 hours. Doctor, yesterday night my heartbeat was 120. What happened after that? Yeah, after 15 minutes it was all fine. So definitely this is what is called as technology-induced psychological issues. It can cause so much of anxiety in a patient who are nearly normal also. These are issues from patient's point of view. Now let's see issues from the doctor's point of view. Yeah, if you are using any mental health app, for instance, let us take M-Fine or any Practo or any video calling app. So the first most important thing is authenticity about the patient's information. We don't know who exactly is talking. We don't know whether the patient is talking about himself, herself, or is it about a friend. Especially this becomes a problem if we are dealing with a psychotic patient. So once they receive prescription from us, they might be using the prescription that we write to some other person without our knowledge. So authenticity about the patient's information is at stake if we are not seeing a patient directly and by using any mental health technology. Then obviously this is a practical issue. We all have done video consultations and other telephonic consultations during the COVID time. But practically, follow-up is very less as far as online consultations are concerned. So when compared to personal consultations, physical consultations, follow-ups are a bit less when compared to physical consultations. It is very tough for us to treat patients with suicidal ideation, those patients with psychotic symptoms as far as any telephonic consultation is concerned. And along with this, we need to know about the medico-legal aspects also, or else we'll be in soup. This is also not an uncommon issue these days. So a few patients, they bring their mobile phones and they start recording what the doctor says. So we fall prey to this technology if we are talking about a marital conflict. So if there is a slip of tongue from us, they can make use of it to file a case against you. Okay. So recording, even phone recording, even this is also technology. Even this can lead to disasters as far as doctor's practice is concerned. Now let's see issues from technical side. So we are not very sure about the proper diagnosis and treatment as far as any mental health app is concerned. Even in our clinical practice, sometimes it is very difficult for us not to diagnose, at least to come to a probable diagnosis, whether it is schizophrenia, obsessions. If a patient is presenting to us with symptoms of schizophrenia, obsessions, and also depression, it is very difficult for us to place him at least to have some provisional diagnosis. I don't know how far mental health apps will be able to do it. Well, If you open Google, there are so many things like 3 months doctor course. Unnecessarily, we have studied for 5.5 years, right? So there is a 3 months doctor course. Doctor Bennett 11th in May. This is much more fantastic. Yeah, the MBBS doctor become a doctor. So these apps are definitely not equivalent to any doctor. We need to understand that. So there could be some apps which are not technologically very sound, which can give improper diagnosis to a patient, which can improperly guide a patient, finally leading to a poor prognostic outcome to the patient. Again, about the privacy. Let us be very honest. How many of us really go through all the terms and conditions before we go for a tick? None of us, right? If you are downloading an app without reading any terms and conditions, we are going to tick it. Yes or no? So we don't know what app is providing information to which source. We absolutely don't know. So privacy is a very big issue as far as the technical issue is concerned. So with all these issues, this is the summary. So we talked about various platforms to share the mental illness. Then we talked about demerits from patient's point of view, demerits from doctor's view, demerits from technical point of view. And to conclude, yes. So this is a paper clipping from Australia. Patients have been waiting for a year to see a doctor. These mental health apps are absolutely essential for those people who have such a long waiting period to see a doctor. But as far as Indian scenario is concerned, patients not even wait for even an hour. There and here the patients don't even wait for an hour. So they get extremely frustrated if they keep waiting for an hour. So probably for those population who don't have so much of access to the mental health care system and to see a professional, probably for those countries, mental health apps could be much more beneficial when compared to a scenario like India, where people call up at 4:15, doctor, I need an appointment at 6:15. Yeah, a patient gets an appointment like that. So probably at this point of time, at least, definitely mental health apps and appointments, they are not of much use. That's what I personally think. And I think there are so many psychiatrists, young psychiatrists, those who are not even seeing 5 to 6 patients every day, even they sit for 3 to 4 hours. At this point of time, probably these mental health apps could further deprive the young psychiatrists from the OPDs. This is a distant view, in fact. So this is an article by Dr. C.J. John and David, who even this is a practical experience. So be wary of Dr. Google. So this is also a practical experience. Once you sit in the clinical OPD, you start writing a prescription. The patient goes home, reads all the side effects of a drug. The next day, the patient comes, doctor, I don't want this drug. This is a common experience for most of us, especially those people who are treating software people. Though we try to convince him that these side effects are very rare and we don't very often see these side effects, but they don't want to take this medication. Yeah. So in fact, these technologies are making the patient away from seeking the proper treatment, in some patients at least. So to conclude, technology is always a two-edged sword. It will bring in many benefits, but it also brings many disasters. Thank you so much.
Thank you, Dr. Lokesh. That was wonderful expression of your thoughts, condensing into a brilliant lecture about the demerits of technologies. You have gone through all the demerits of technical view, doctor's view, and the patient's view. It was well summarized, and I can see that personalized touch that you have given in your colorful slides, actually. So I think that's what makes the presentation brilliant as well. Yes, now I would ask Dr. Fani Prashant for 2 minutes to comment on what Dr. Lokesh has said.
I would agree that technology is a double-edged sword. There's no doubt about that. Okay, whether the benefit outweighs the risks which are involved is what we are looking at. Okay, and then we are not looking at a general population which are trying to download anything which is available, from particularly patient population which are directed towards a particular technology or a particular treatment therapy. That I have this patient who has phobia. I need this VR treatment will help. Take this. Okay, so there are, that is where I would feel that psychiatrists should become a part of the team with the technology so as to understand, and then these have not been standardized. Most of these apps have not been standardized. Okay, they have not have any validity. Okay, whether we as a group or a institution or a society should actually become a part of a technological advancement, and then okay, monitor these which are really genuine, which can be used, certified by this society to be used. Okay, then we'll help a larger society, okay, to use mental health apps in a safe way. Okay, that's what I would say.
Thank you, Dr. Fani Prashant. That was brilliant rebuttal. Now I would ask Dr. Lokesh Kumar to say 2 minutes about his defense about the Fani Prashant's.
Yes, sir. So I definitely agree to what Fani Prashant sir said, definitely. But see, seeing things in a practical way, that's what we need to think about. See, undoubtedly technology is a wonderful thing, because without technology we wouldn't be sitting here having such a wonderful presentation. But we need to see the practicality of the issue. How far is the technology is going to help a common man? That's what we need to address the issue. See, it's like introducing a technical app or this kind of medical psychiatric app to a patient. It's something like even before, it's like throwing a seed into an uncultivated land. Okay, so even the precious seed which can grow into a wonderful plant, if it is thrown on an uncultivated and infertile land, it is not of absolute use. So first and foremost thing, what we need to do is bring awareness about the mental health illness. Today we are in a state where even software people, they are going to all the pujas and they perform all the rituals and all, even before they seek a mental health professional. So this happened even with my own colleagues. So he is a software engineer, and he took his own wife, though he knows that I am a psychiatrist. He took his wife to some faith healer for this kind of doing ritual. So first and foremost thing is, without proper awareness, especially in a country like India, so this is something like using a mental health app is like showing Arundhati nakshatra to a newly married couple. So we don't see anything, but still we need to understand that there is something. Yeah, it's something like that.
Thank you, Dr. Lokesh Kumar. That was brilliant rebuttal as well. I think the weight balances, but then I will leave it to the audience. So anyone in the audience who wants to take a side and then comment. Yes, Dr. Prasad, sir.
First of all, I don't want to take a side. The primary purpose of this debate, and I first of all congratulate both the speakers for bringing up what we wanted. What we wanted is that there is always the positive side and negative side, and both the debaters has brought the points, and I congratulate. The second point, right now, I mean, I'm just adding to what both of them have added to the learned audience. One of the reasons why we kept last your topic is so that a lot of people are staying in the audience, and you see a lot of people are staying in the audience. Thank you once again. Right now, a lot of things what you said is also governed thanks to the COVID. Telemedicine and telepsychiatry guidelines are governed by an act. I thought that is a communication of a fact to all them. Most of us, as we know, not knowing a law is not sufficient. You might commit an offense, but not knowing a law is not a protection. Likewise, not knowing a technology, and technology is coming like a flood. So you will have to sail with them. Both of you brought out these points only. Both of you brought out the day-to-day issues, saying that our patients will come and talk, Dr. Google or whatever. But knowing the mental health technology, you focus more on the app, and you debated for your point because it is against. And he debated from the positive side, saying that there are a lot of users. But the fact remains, a lot of these apps are totally out of our control. So my suggestion in the end to the larger audience and to both of you, of course, that here both of you have won. According to me, both of you have won because you put your points quite, and you didn't fought on some other small reasons. You bought on a major reasons, both of you. Your cautions have to be taken care by every one of us, because you can be. Likewise, his own suggestions that lot of opportunities we have to use. I myself at this age use lot of this technology in my practice. So the youngsters sitting there and not so young people who are sitting this side, who argued for both the things, the take-home message is, and the theme of this topic, this conference is, the impact of mental health technology and the changing phase, and I would say the changing practice. Each one of us are using this. From my own experience, most of the time I ask my patients, I check the health app, because that give me a sleep. I ask them how whether, and especially those who have smart watches, we can do. So there is a positive side, but there is also a negative side. I thank both of you, and I think I'll leave it to the others audience.
Anyone from the audience who wants to add? Dr. Ashok Reddy, sir. In fact, in 2015, one of the first lectures that we have presented at ANSEPS, Bhopal, was myself and Dr. Ashok Reddy. We presented a symposium, and that was the opening of that telepsychiatry and technology as well in mental health. From there onwards, every year we have been presenting at the ANSEPS the same symposium, but with advanced and updation as well. Yes, sir, Dr. Ashok Reddy, sir.
So now we are just discussing about application of mental health technology, good versus bad. There is a debate what we have. So there is one approach in providing service to the patients what we have. We are using this as a tool to help us. They are good and bad. Any treatment will assess the risk, benefit, and then use. Both are there. Even for medicines, risk is there, benefit is there, we use it. Because the benefit is more than risk. Similarly, technology, we have to assess both and then use. We should not forget about the second component. Risk component, we have to be always keep at the back of the mind. See, take care of this risk and then proceed. We have to move forward using technology, taking care of the deficits which are there, and always there are methods to take care of these deficits. Like the Dr. Lokesh is present of anonymity. Suppose we provide consultation continuously on telemedicine, probably anonymity can continue. So the answer is, like what I do is I provide consultation. First consultation is always in-person consultation. And subsequent consultations are alternate consultations are online and physical consultation. So there is no question of anonymity. We can take precautions like this. So we have to use the precautions and move forward. For every thing we have, like awareness, it is increasing awareness. You told that the referrals to the doctors might be coming down. But in fact, if I ask my patients who has referred you, 10% of patients says, I searched in the Google and came to you. These are not referred by another doctor or another friend or another old patient. They directly search in the Google and then come forward. So technology also increase the number of patients, not only decrease the patient. It doesn't decrease, actually it can increase the patient. By increasing awareness of their potential possibility of illnesses, they try to confirm it by coming to the doctor. I think there are various means of counteracting all the risk factors. So we have to take care of the risk. So we have to look from both the sides, what you have pointed and what he has pointed, analyze and then move forward with the technology. Always problems will be there. Solution is also always there. Look for a solution. And then proceed. Thank you. And I want more people to use technology for caring our patients.
Thank you, Dr. Ashok Reddy, sir. Those are the very wise words, balancing both technology as well as the human touch as well. Anyone else from the audience who wants to comment, who wants to give suggestions, or who wants to voice their opinions? I mean, being a private practitioner, let me tell you, being a private practitioner and use of technology, that is mainly telepsychiatry, is a challenge. I mean, has to be done, or the one visit has to be a physical visit. So there were so many, clauses which were there regarding the telepsychiatric guidelines, and there was confusion because I mean, what is called as, let me confess, practitioner, we tweaked out processes which could fit into the telepsychiatric guidelines. Plus, we could, what is called as, generate in who had to adopt this kind of technology to serve them in to those particular divorce each other, or we should not use. There will be demerits, but we can't predict the demerits as of now. As the time goes by, it's a learning process. It's a new process that is coming up from our side as well, from the technology side as well. Technology itself, they will adapt as well to suit our needs, and we will change the technology to suit our needs. So I think that's what is the final say, I would guess. And I would end this session. Yes, madam, anyone?
Very non-scientific comment I would like to give here. जैसी करनी वैसी भरनी, ना माने तो करके देख, जन्नत भी है दोज़ख भी है, ना माने तो मर के देख. Thank you.
That was a very good line share from to conclude this session. I would now give it back to the chairperson. Take over the session.
Thank you, Dr. Fani Prashant and Dr. Lokesh and Dr. Naresh, sir. It was a wonderful discussion. I would like to just give one statement before we conclude this session. It is popularly said that it's not guns that kill, but men who kill. The same goes with this technology too.
Thank you.
I might also want to close with the chairperson's permission. See, if you do it, you're going to gain it. If you're not going to do it, you're doomed to do. Because either way, the mental health technology, new technology is going to be with us and be with the patients as well.
Thank you, sir. Now I request Dr. Chaitanya Deepak Garu and Dr. Naresh Vadlamani Garu to felicitate our speakers. I also request Dr. Fani Prashant Garu and Lokesh Garu to hand out the token of appreciation to our chairpersons. Next session going to be the valedictory function. So,
we'll start the valedictory function. Thank you very much. My heart is totally happy today. We have the young psychiatrists, the bright future of psychiatry lies in you, and waiting till the last moment. And in a conference, a live conference, after a length of time of break and webinars, I'm very happy to see you all right present in this. Thank you very much. We'll start the valedictory in the next few minutes, and we will learn to hear from you in the end during the valedictory meeting. What are your reactions, and of course, what are the suggestions for the better improvement of this conference? Thank you.
A very good afternoon, everybody. I feel honored and glad to invite all the dignitaries onto the dais. First, I now request our President, Dr. Ramasubba Reddy sir, to the dais. I now invite Dr. Ashok Reddy sir, Chief Guest of this function, to the dais. I invite our Vice President, IPS, Telangana State Branch, Dr. George Reddy sir, to the dais. I invite Honorary Secretary, IPS Telangana State Branch, Dr. Pawan Kulkarni sir, to the dais. I invite Dr. Narayanan Rao sir, Treasurer, IPS Telangana State Branch, to the dais. I invite Editor Dr. Sai Krishna sir to the dais. I invite Organizing Chairman of TS Psycon, Dr. Prasad Rao sir, to the dais. I invite our Organizing Secretary of TS Psycon, Dr. Chaitanya Deepak, to the dais. Now I request our Honorable President, IPS Telangana State Branch, Dr. Ramasubba Reddy sir, to take over proceedings. Thank you.
This is better. Holding the mic is difficult. Again, I will come there. Good afternoon to all, respected dignitaries on the dais and the other delegates. I think we came to the last part of the conference. All are enjoyed very well. The accommodation, arrangements, and academic programs. The conference is organized extremely well by Prasad Rao sir and Dr. Chaitanya. All the programs are academically rich, relevant to the present day circumstances. The oration of Dr. Sudhakar sir is useful in knowing the legal aspects of marital problems. Presentation by Dr. Sri Lakshmi, it's also helpful and cleared all doubts regarding the prescription of drugs to the pregnant woman. And adopting emerging technologies in day-to-day life, in the practice, and internet gaming disorders are most relevant topics. And on the whole, all the topics are very relevant. Yesterday evening, all of us are enjoyed the cultural programs. The cultural programs by Ilaram Subbareddy sir is a highlight, and the snaps of Athreya songs relevant to mind and its usefulness in psychotherapy was well explained. And our senior psychiatrist and past president of Telangana Psychiatric Society, Dr. Sridhar Raju's mono action, and the skits by ASHA doctors, ASHA postgraduates. All these programs are very much entertaining. Finally, the conference is excellently organized by Prasad Rao sir. And sir gave me the privilege of taking over the charge in a physical form, that too in the Taj Krishna Hotel in front of 300 delegates. Thank you, sir. Thank you, one and all. Next, I request our chief guest, Dr. Ashok Reddy sir, to deliver the speech.
First of all, we are grateful that IPS Telangana State Branch for giving this opportunity to organize the conference to Asha Hospital. The rich organizational experience of Dr. Prasad Rao, under whose leadership the team has worked, made this program so perfect, so useful, so enriching to all of us. So we are thankful to the Asha team, and Dr. Prasad Rao was involved not only just doctors, but he has taken interest and saw that each category of the Asha hospital is involved in the organization of this total process. And they felt belongingness, that okay, Asha hospital, everyone is part of this conference. I think this gives a lot of satisfaction to the total Asha family. Second is, in addition to the regular conference, the sports and cultural activities were organized one day before, and where all the families have come together. And especially they have arranged programs to empower the women. They have arranged the tournament, the shuttle tournament for the women psychiatrist, which was well enjoyed by the participants as well as the dignitaries over there. It is a very appreciable activity from the organizing committee. Then they selected a very young, talented team of speakers. We see most of them are young psychiatrists who are presented. Young psychiatrists have more information, knowledge with them compared to the older generation. Whereas senior psychiatrists have more experience and wisdom. They made a mix of both to see that the delegates could get the maximum knowledge out of this conference. And encouraging the young psychiatrists is a wonderful idea from the organizing committee. We have to appreciate this approach in encouraging the young psychiatrists, because they are going to, this momentum will pick up and they are going to serve these learning sessions for the almost next 2 or 3 decades. That will help, in general, the knowledge update for all of us to a great extent. And making the conference a physical conference, for the last 1.5 years, the COVID has forced us to lead an autistic life, in fact. We were sitting in our own homes, looking at the screens, participating through webinars, which is not so enriching experience, but we are bound to do that. We have not enjoyed so much when participating in the webinars. We could not concentrate so much. We are also doing some other activities while sitting before the computers. Only partly we could learn really to fact. But here, we cannot escape and go out. We are in the hall, we are learning. And this is a more 3D experience compared to 2D experience when it is on the laptops. So it gives more knowledge. We can imbibe more knowledge through in-person programs compared to the webinars. Our attention will be more concentrated here. Even when I thought of having the ANSIPS 2020 SVS Medical College, when still the COVID number was more, when the college administration was slightly reluctant to permit in the college premises, but I had to convince them. The effectiveness of conference is more only if it is personal. And we are missing that life. Life means active, moving together, social life. We are missing that. So finally I had to convince them we are going to follow all the protocols of the COVID, and all the speakers, presenters will be physically present. Audience will have the option of physically present or online. So I started with the hybrid program so that we'll make it more live. The life is infused there. And there is taken up much forwards by the TS Psycon 2020, which made almost more physical, less online. I don't know how many out of 350 delegates were registered. I think the organizing secretary is going to give the list, how many were offline and how many online. So all these approaches, so all the delegates have enjoyed, they have acquired more and more knowledge, enjoyed the feast, enjoyed the cultural activities, So this is what I would try to convey. And thanks the organizing committee for giving us all these benefits. Thank you.
Good evening. Most of the things are already spoken by President Sir and Ashok Reddy Sir. I just want to reiterate the same thing. It was despite the deadlines, extensions, they have pulled off a beauty here, and it's done in a very grand scale, I should say. And particularly, this is very special to me because I am taken as a General Secretary under organizingship of Prasad Sir and my best friend Chaitanya. We know him we have been associated for 13 years now. So in that way, this conference is very special to me. And the other reports which will be presented by the organizing secretary in short time. Thank you.
Good evening, everyone. Thank you, Ipstsb, for giving us this opportunity, and I would glad to say that this conference has been a huge success with the governor inaugurating the function and so many delegates coming in spite of the COVID and all those restrictions. And most of them have followed the protocols of the COVID and all, were wearing their masks, sanitizing, and maintaining social distance too. Total of 344 delegates have registered for the conference, and there was an average footfall of around 280, with around 400 people attending the banquet. And there were more than 20 papers like in free and award paper and poster presentations that have been presented, and there were orations by senior faculty like Dr. T.P. Sudhakar and Dr. Niranjan Reddy Garu, and other various scientific sessions which were quite educative and quite informative for everyone. Thank you.
Anyone from delegates? Any feedback from delegates regarding the conference?
Thank you, sir, for giving an opportunity for the delegates to speak their feedback. Yeah, and it was a fantastic extravaganza. Let me say it was a festival. I mean, really, we waited for 1.5 years, and this, I mean, it's not like a Telugu festival or Deepavali or Dashera or something. I think it's like a TS Psycon festival. We had 280 delegates who were there here in the hall. They were there colorfully with their families. I mean, we had, yesterday night was really a festival kind of an atmosphere. There was singing, dancing. There was actually even the film program was also there. And that was the highlight as well. And we had delegates coming from across the other states as well, in the southern states. Dr. Uday Kumar, Dr. Suresh Kumar, Dr. Ramakrishnan, the president of the South Zone of Indian Psychiatric Society. He was here as well. So, I mean, it's like back to olden days. So we can say that pre-COVID days, that we can say, that was an era which we all enjoyed. Personally, having our own, say, interactions, social gatherings we had, and it reminds us of those olden days yesterday. And it was really a fantastic feast. Apart from that, the academics, the topics chosen were very well chosen. The speakers were very well knowledgeable. And the theme of the conference, which is the impact of technology on mental health care and the changing phase, it was very apt. And for the last 1.5 years, though we have been using technology on Zoom, we have been having seminars, we have been having webinars, I think we got burnt out. And that's the reason why everyone has come out in large numbers. The venue was fantastic, it was extravagant. And the organizing part, the whole organizing committee headed by Dr. Prasad Rao sir, Dr. Chaitanya Deepak, the ASHA team, I think they did a very fantastic job, meticulously planned, right, looking into every small detail. And apart from that, I mean, being a cricketer myself, we had a real festival after nearly 1.5 years again, right, and we enjoyed. There were 4 teams. I mean, usually when we play a cricket match, I think we had to beg for, say, farmer people to join the team, or we have to add some additionals off the field as well. But I mean, day before yesterday, there were 4 teams, and there were extra players as well. So what it shows is that people were eager to come out, and we were enjoying the whole day. The facilities provided there was fantastic. The ground was fantastic as well. Overall, I can say that it is the best conference in the coming years. And probably people will take this as an example, or this as say what is called as a epitome to emulate in the next few months or coming months for the other conferences to be conducted. Thank you very much for giving me this opportunity.
Thank you, Naresh. Any other delegates? You want to share your experiences in the conference?
Good afternoon, sir. It was an excellent academic feast for DNBs like us, and whether it was the scientific programs or cultural and sports activities, all were well organized, and there was no divide between the seniors and juniors. Actually, it gives us a lot of confidence, and Professor made sure that the youngsters were given, or they are instilled, lot of leadership qualities, and we were assigned tasks, and we were encouraged and motivated to do our best, and we were never made that we were juniors and the rest is senior. Actually, we were made to feel that we are part of a family. It was an excellent organization, and whether it was sports activity or whether it was cultural program also, all of us, like, irrespective of the senior-junior divide, we contributed in our own way. And coming to the academic program, like from mere textbooks to this technology conversion, this is very important. Like when we do video consultation for our seniors, we are also learning new clinical experience, how to deal with a patient and how to be like we have to be cautious about certain things while doing a video consultation also. So these experiences are very good, and we have to incorporate this technological advances in our practice. So it was an excellent academic feast as well as a cultural and entertainment. It's a full pakka conference. Thank you once again.
Nice. Please come.
Sir, I'm Dr. Sai Krishna from the All India Institute of Medical Sciences, Bibinagar. Ever since this brochure was shared in the WhatsApp group, I was so excited because I was making my re-entry into Hyderabad after around 29 years. And since ANSIPS happened in 2020, Kolkata, this was the first conference that happened, and it was a fantastic effort from the organizing team and the ASHA team as well. And I was so impressed by the award papers that were presented yesterday and the sessions that I attended today, and the icing was a debate. And to me, a sports person, the first day of the conference that happened there in Samshabad was the best. We thoroughly enjoyed that day. Congratulations again.
Anyone from women delegates? Purnima Garu?
Thank you for calling me onto the stage, sir. Otherwise, I wouldn't probably not have picked up the courage to talk. First, I'd like to congratulate the entire Asha team, all the pleasant youngsters smiling away at all of us oldies and making us comfortable. Special thanks to Dr. Prasad Rao, sir, for taking on my application even after the closing date, and Dr. Chaitanya Deepak. Very, very special thanks to all of you. After 1.5 years, it felt like, the children all coming back home. All the scattered children coming back home. And thank you for making it such a homely and such a lovely experience for all of us. Not the venue, not the food, these are all typical of every conference, but the affection that goes, that it's so palpable to all of us. I think this is what makes the conference something that we would love to come back to. Thank you so much, and we are waiting to see many, many more coming from the Asha team. Thank you.
Thank you, Purnima. Any other delegates? Anyone from postgraduates? Sai Krishna, no? Hari Jappeda. Okay. Then we will go to the next one. Gets by organizing chairman and organizing secretaries. Distribution of prizes and medals.
One second. The award for late G.V. Sitaramaya and Mrs. Krishnalila Memorial Award for the year 2021 goes to Dr. Varsha S. Plankte for knowledge and attitude towards delirium amongst doctors of different specialty. Next is Dr. B. Anand IMH Alumni Poster Presentation Award. This award goes to Dr. Konda Pujita Reddy for her poster on a rare case of recurrent psychosis with hypothyroidism precipitating catatonia. Pujita, 1 second. Now PG quiz and UG quiz runners up TS Psycon 2021 goes to Dr. Pratishta Pita and Yashaswini of Mallareddy Institute of Medical Sciences. This is runners up, sir. Sir. And the winners for undergraduate quiz goes to Dr. Raviteja Reddy and Kadari Priyanka of Medicity Institute of Medical Sciences. Medicity, on behalf of Medicity. Yeah, Dr. Gauri Shankar is going to collect on behalf of Medicity. Next, late Mauludi Shivkumar Reddy Memorial PG Quiz Award. Runners up are Dr. Atif Ahmad and Dr. Sadma Siddiqui of Deccan Medical College. This is runners up, sir. Runners. Checks the media. Sadma, 1 second. You will receive a check also for this. Yeah, winners of the MS Kumar Reddy Memorial PG Quiz Award goes to Dr. Madhur Rati and Dr. Nisaruddin Ahmad of IMH Hyderabad. PG Quiz Award. PG Quiz Award. Check.
Dr. Sai Krishna.
Dr. Sai Krishna. He's a cricket winner. Okay, okay. Cricket winner.
సెకండ్ పోస్టర్ ప్రైజ్.
ఇంకా ఉన్నాయా ఏమన్నా? ఇంకేమన్నా ఉన్నాయా?
సెకండ్ పోస్టర్ ప్రైజ్ అమ్మాయి గుర్తులేదు. సెకండ్ పోస్టర్
సౌత్ జోన్లో మళ్ళీ క్విజ్ ఉంటుంది.
వీళ్ళిద్దరు సౌత్ జోన్ క్విజ్కి వెళ్తారు సార్. ఇదేమో అక్కడ సౌత్ జోన్లో అవార్డ్ పేపర్కి
మర్సీ డాక్టర్ మర్సీ
డాక్టర్ మర్సీ ఏంటి అమ్మాయికి సెకండ్ ప్రైజ్. ఓకే ఓకే సార్, ఓకే సార్. ఇది సౌత్ జోన్లో
అవార్డ్ పేపర్స్కి
పంపిస్తారు.
I'll get you the certificate later. Mark this one.
Sound ఎందుకు మళ్ళీ? Dr. Varsha from Gandhi Medical College. This paper will go to South Zone. Who is the Dr. Varsha? PG quiz winners and UG quiz winners, they have to go to South Zone conference. Right.
Memento to the Chief Guest Dr. Ashok Reddy sir.
Today is one of my most happy days to remember in my life, and thank you all of you for giving me the opportunity. Dr. Jagannath, Dr. Minhas, and the current team, Dr. Ram Subba Reddy Garu, George, and the Pawan, and the entire EC. First of all, Asha Hospital wishes to express on, and for Asha Hospital, I am expressing my happiness. I know, to start with, there was an initial hesitation on the behalf of EC. They wanted a hybrid webinar. I want to tell 10 minutes of my story. Please, Dr. President Garu, I have decided, when I decided for live conference, I want every one of you sitting here to know that I have done a great research. I directly communicated in the month of April, third week or so, to Dr. Mukherjee. If some of you know her name, if you can Google and find out, she is from the University of Michigan. She gave one of the best predictions of the COVID pandemics likely to occur in India. She was actually suggesting, see, when I sent a mail in the third week of April, and that was the time when the EC meeting was supposed to happen, she replied back, and there was a back-forth communication. She very clearly said that the pandemic is going to end in the month of June. It's not likely to last more than the June. She said clearly that second week to third week is the time. I specifically asked for Hyderabad. Thankfully, the professors of IIT Hyderabad, again, they were giving the role model. I also sought, and some of you might be atheists, astrologically whether my days are good or not. And they said July 13th onwards, there won't be any problem. So, taking this too, some of you might not believe it, but this is my way of looking at it. When we are fighting a pandemic about which we don't know, so I took astrological help. Incidentally, just now as we are talking, the astrologer who predicted just now talked to me. So both based on that, I was very strong in my argument. Maybe I did hurt some of you sitting on the dais when you wanted to only a live webinar. But the third point was more important. This one too, the first one was a scientific one, probability. The third one, we have done a random survey of asking 70 people, do you want live conference or a webinar? Don't be surprised. 96%, except 2 people, everyone wanted live. So I was so strong. So that was the research went. Now once we have decided on the conference, this is a time when there was a brainstorming going on. Chaitanya, Sweta Reddy, Ajay, Amulya, and Sandeep. We were the core group, and of course all my residents, Madiha, Hari, Chandresh, Navya, and Sakib. We had done a brainstorming. I personally decided, one exception, I'm the only exception, rest all are less than 45 years. The faculty. The faculty means the one who actually gave lectures. We have carefully chosen, and Sri Lakshmi, if she is here, I thank her. And I did consult some of them. Regarding the theme, I thought mental health technology is the one. Apart, we could have chosen, there were a lot of brainstorming. COVID was one, pandemic was one, the new wave, what's going to be, these kind of themes. But I thought we had so many pandemic webinars, so it's better it will be repetition. But let us look into a new thing. Thank you everyone. Thank you EC. Jagannath, where is he sitting? He is the one who gave me a free hand. Thank you, Jagannath. Thank you, Jagannath. Thank you, Jagannath. Regarding the planning, after the faculty, the science part, as you have seen, today also we planned such a way that Sri Lakshmi would be the opening batsman. At least for her sake, a lot of people will come. Yes, people did come, but we started about, I think, 20 minutes late. One of the message I really want from this conference is the science should go on time. I would say probably we were about half an hour late yesterday, maybe less than, today we are on time, really on time. Thank you very much, ladies and gentlemen. And we had, I think I'm most happy when, as I think Sai has said, every year we are having only cricket matches for men. So there was a gender discrimination. So this year we actually had for women shuttle tournament. 16 women participated. 2 singles, single match and doubles match. And women also, because they are known for their artistic skills, we had a artistic competition. Almost 9 paintings by the young postgraduates and young psychiatrists. Thank you very much. You made my day. And I think this is a time when I thought we should club. You will be surprised. 338 is the figure I think Chaitanya has told, but that is the registered delegates. We thought among the registered delegates, there might be somebody who would not be coming. Not many. Actually, only 22 or so did not come and report and take the bag. Yesterday, as Chaitanya has reported, there were 400 for the dinner. Actually, that's the great part. Again, I thank Sakib, Sweta Reddy Garu. Where is Sweta Reddy Garu? I want you to come, little friend. She is the heart and brain behind lot of this. Very obsessive, very organized, very systematic. Sometimes cheating me. Sir, you will take everything. Sir, you will take everything. But she is the one to be praised. Thank you very much, Sweta. The entertainment part, as you have said, and I'm most happy because, one, it is our own. Unlike many conferences, there's no loud noise. There is no, even, I would say the cocktail party was going so smoothly. Thank you, each one of you. This conference is successful mainly because of you. The science, I was very wonderfully struck in. I don't know your name from Kakatiya Medical College because it's difficult for me to pronounce. Yeah. So you said your name, but right from him, he is 30 years old, but I have gone through the ages. We have 26 years plus, of course not counting the undergraduates, and the senior most was 86 years, Dr. Niranjan Reddy Garu. That is the age range which came to the conference. And this time, I did invite psychiatrists from Andhra Pradesh. In fact, President Ramesh Babu is supposed to come, I don't know. Last meet he couldn't come. IRS Reddy came. Uday Kumar, our South Zone President, incoming South Zone President, and the current South Zone President and Secretary came. So this is the bonhomie of an academic conference, and at a very personal level. Now, I will take just another 5 minutes to express my gratitude. Any conference of this large is by the support of pharma team, and at a very personal team. Lot of planning has gone into this conference by my team, and last but not the least, Chaitanya. He is like my son. Whatever I said, he would say yes. And Madam Governor, she actually wanted to come till yesterday morning. There was a processionist or some agitationist stopped her. But on the whole, as I said, I'm most satisfied. Man today. Thank you very much. Thank you very much. And I also celebrate my 38th year of my wedding anniversary with all of you today. Thank you very much. Yesterday night at 12 o'clock, we had. Now this is my honor. We take from the organizing committee to felicitate the most important people who made this conference more successful. I don't need to say openly, but it is the pharma team. The pharma companies professionally working with us, each one of us, and I want to felicitate each one of them. As a team.
I would like to first call upon Sun Pharma. Crescent. Next, Linux. DD Pharma. Next, Alchem Pharma. Next would be Intas Pharma. Next, Hans Pharma. Ipka. Micro Labs. Excision Pharma. Eris Pharma.
No, thank you very much. Now, so I'll close this with saying for the youngsters sitting behind, I want each one of you to ask questions during the scientific sections in the future conferences. Don't be shy. As you talk, you learn your leadership. Thank you very much.
Zydus Pharma.
So, good evening, one and all. Like all good things should come to an end. We have come to the end of conference, and I take this opportunity to propose the vote of thanks. I would like to thank the Chief Guest, Madam Governor, Her Excellency Tirumati Tamilisai Soundararajan, for accepting to be the Chief Guest and inaugurating the function. I thank Dr. Ramakrishnan Sir, IPS South Zone President, Dr. Ravindra Reddy Sir, Chairman Telangana State Medical Council, for being the guests of honor. I thank Dr. Ashok Reddy Sir for accepting to be the Chief Guest of today's valedictory function, and also guiding us for smooth conduct of this conference. I would like to thank Dr. Jagannath Sir, immediate past President, Dr. Minath Sir, immediate past Secretary, Dr. Sai Krishna, Dr. Editor, past Treasurer, and Dr. Mayurnath Reddy Sir, Awards Committee Chairman, and chairmen and members of various committees, and all the EC members of the last year for their untiring efforts. I thank all the patrons and advisors of this conference for the timely guidance and support. I thank Dr. Prasad Rao Sir, Organizing Chairman, Dr. Chaitanya Deepak, Organizing Secretary, TS Psycon 2021, and their team for conducting this wonderful conference. I thank all the speakers, chairpersons who have come here and shared their wisdom, and all the delegates and postgraduate and undergraduate students for attending this conference. I thank all the pharmaceutical companies who have supported and sponsored events in this conference. I thank all the persons from the print and electronic media for carrying out the message and outcomes of this conference to the public. I thank the management and all the support staff of the venue, Taj Krishna, for looking after all the necessary arrangements. Thank you one and all. Thank you once again.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request all the EC members kindly rejoin in the same venue after 10 minutes break for the first EC. Thank you.